So, namaskar, good morning, and a warm welcome to respected faculty, IDVL Bihar branch, and all delegates. I'm Seema Nair, AGM Marketing, Ajanta Pharma, and take this opportunity to welcome you for this academic extravaganza on atopic dermatitis in this opportune month of October, which is celebrated as National Eczema Awareness Month. We begin today's program with the auspicious lamp lighting that symbolizes darkness to light. And to do the honors, would like to call upon all the faculty for today's session, along with Mr. Madhusudan Inamdar, Cluster Head Ajanta Pharma, and request all doctors to please come ahead for the lamp lighting, sir. So Dr. Sandeep Pandhar sir, Dr. Sahana ma'am, Dr. Abhijit Saha, Dr. Abhishek Jha sir, Dr. Vikas Shankar sir. Yes, all the chairpersons, moderator, and the panelists could please come ahead for the lamp lighting. Thank you, doctors. Welcome, sir. So Ajanta Pharma today is proud to associate with Society of Eczema Studies, the brainchild of Dr. Sandeepan Dharsar. This day marks the fifth collaboration. Previously, we have had sessions at Hyderabad, Lucknow, Jaipur, Amritsar, and today in the beautiful capital city, Patna, which is known as the seat of justice, fine arts, and learning, with renowned names like Aryabhatta and Chanakya from here. The most prominent personality who had touched multiple lives and helped scores of patients, and the most prominent name in dermatology was respected late Dr. Amar Khan Jha Amar sir, and his passing was an end of an era for us. To honor sir's memory and to commemorate this occasion, would request few doctors to please come on stage. Dr. Om Prakash sir, Dr. P.K. Roy sir, Dr. Ravi Vikram sir, and Dr. Abhishek Jha sir. Would request you to please come onto the stage, sir. And to say a few words on this, would request Dr. Sandeepan Dhar sir to come on stage.
Dr. Abhishek Jha and Dr. P.K. Roy. After I finish. Good morning, esteemed colleagues, friends, beloved residents and postgraduate students, officials and executives of Ajanta Pharma Limited. It's a great day for me to be here in this historic city of Patna, with which there are a lot of memories which are associated with me. I first welcome you all for this meeting on atopic dermatitis by a joint venture of SES, IADVL, Bihar and Ajanta Pharma. Well, way back in 1992, when I have just passed my MD from PGI MER Chandigarh, the National Conference of Dermatology was held in this city, and I still do remember it was Ravindra Bhavan, the venue. And the organizing chairperson of that conference was Dr. R.P. Okhandiar from Bhagalpur. Many of the youngsters may not be knowing his name, but you certainly know the name of the dynamic organizing secretary, late Dr. Amar Khan Jha Amar. And he organized a phenomenal conference, and from that very day we developed an intricate bondage which was viable till he had gone for his heavenly abode just a couple of years back. 1992 is a memorable year in my life because my atopic dermatitis work for the first time in entire IADVL got a recognition because in that conference I was awarded with Best Paper Award presentation Dr. B.B. Gokhale Gold Medal in Patna National Conference for my work on staphylococcal colonization and its role in atopic dermatitis, which is still quoted all over the world and it is quoted in almost all textbooks and all monographs of atopic dermatitis. Besides that matter, I found a young dynamic person whose name is Dr. Amarkant Jha Amar that day, who gradually over the period of time became my elder brother like figure. That was the kind of relation with him. Umpteen number of times we have met. I remember even in 2018, before COVID, last time when I had come to Patna for a program on fexofenadine, he came like Sandeepan come, always used to be with outstretched hand and hug on the chest. And that man, I have never seen his face without smiling. Always used to be smiling. He is one of the most popular. Please do remember and feel proud of him that he is the son of our entire Eastern Zone, not only son of IADVL at the length and breadth of IADVL in the country. And his contribution to Indian dermatology is immense. And his loss is irreparable. We all felt very shocked when we heard about his untimely death. It was not expected to us. But nevertheless, now it is time to pay our homage and tribute to this great soul who has given a face to enter Eastern Indian dermatologic scenario, pan-India. My salute to him, Amar Dada. Amar Dada, Amar Rahe Hamesha. With these few words, we would like to lamp the light and commemorate Amar Dada's. Dr. P.K. Roy showed me just now a very fond memory. Amar Dada always used to be associated with Dr. P.K. Roy. You know, so he used to go, Amar Dada and P.K. Roy, they were as if they were just like shadows. I have always seen them together over last 30 years. And Dr. Abhishek Jha, what you see today as the most dynamic young person of Indian dermatology, I have seen him during his school days. May I request, Professor Dr. P.K. Roy to say a few words about his friend, come elder brother. Huh? Lamp jalana? Sure. Come.
उसके बाद तुम बोलेंगे भाई आओ भाई तुम लोग भी आओ
Careful.
कृपया बैठ जाएं। मुझे लगता है डॉक्टर संदीपन ने मुझे ज़िंदगी का सबसे कठिन काम दिया है, अमर के बारे में कुछ बोलना। 1970 के दशक में हम लोगों ने 1970 और 71 में हम लोगों ने साथ साथ दरभंगा मेडिकल कॉलेज में एडमिशन लिया, और तब से उनके अनटाइमली डेथ 2021 में हम लोग साथ ही रहे। बीच में मैं 5 साल आर्मी में गया था, बट आई नेवर लॉस्ट टच विद हिम। देन आई केम बैक, and my joining the department of dermatology, I can say it was due to Amar Khan's insistence that I come to Patna and join department of dermatology with him. After that, we together, everything that we did for IADVL Bihar, we did together. He was the limelight, he was showing the path, and I was following him everywhere, on every step, till the death. And this morning also, when I saw his photograph, I can't project it here, I could have shown that. He is hugging me when we became superintendent Patna Medical College, and I went to congratulate him. He hugged me such a tight way that I still remember. And for me, it is a very painful thing to say a few words about him. It always brings tears to me, my eyes and all, because for last 72, now 54, 2 years, 21, 70 years, 51 years we are together in every adventure of him. We started with 11 people in IADVL in Bihar. We took it to 197, 156 people in Bihar. Bihar was never recognized on the maps of IADVL all over India. In his time, we became secretary and treasurer. We got the best branch award, and so many things he started doing, which is still being followed by IADVL. One of the flagship program of IADVL is IADVL Chala Gaon Ki Or, which he started, and we are still following it. Every month, somebody of IADVL Bihar, they go to a village, and then there's this IADVL Chala Gaon Ki Or, which was taken up by the center, and it is still doing it. So I'm at loss of word to say everything about it, but then Sandeepan has done so many things, and they already said everything about Amarkant, and my pranam to my friend, and I can only say I miss him. Thank you. And बस ना, और तुमको वेलकम नहीं ना करना है? हाँ? हाँ? आपको वेलकम नहीं ना करना है अभी, और अभी आपका प्रोग्राम नहीं ना शुरू हुआ है? भी हुआ? चलो, मैं बाद में नीचे नहीं जाता हूँ, ऊपर बैठ जाता हूँ।
Just a little bit more to add to it. Amar Dada was not only the face of dermatology of Bihar, he was synonymous with dermatology of Bihar dermatology for more than 3-4 decades. And he was synonymous with dermatology of Eastern Zone also for more than 3 decades. That was the kind of his contribution, his stature, his popularity, and his personality. I still do remember when he first proposed, Dr. P.K. Roy Saab remembers it very well. The other day we were discussing in Calcutta airport when we were going to Ranchi that he proposed that we should have a East Zone, just like South Zone team has got a South Zone, West Zone has got a West Zone, and we formed an East Zone dermatology, and the 3 persons who made this possible, one was Dr. Amar Khan Amar, second Dr. Subrata Malakar, and third myself. We 3 started the East Zone, and the first conference was held in Calcutta Science City in the year 2000. And what East Zone conference now you know and see is all started as a brainchild of particularly one person, late Professor Amar Khan Amar. So my pranam and tribute to him. So can we have all a standing ovation to this great soul? And we'll keep silence, maintain silence for a minute. Thank you very much. Now over to Seema.
And with due permission of Sandeepan, I'd like to start the proceedings with welcoming the Society of Eczema Studies people to Bihar. It is their kind gesture that they have chosen Bihar Patna as a place of meeting. संदीपन सुन रहे हो ना? थैंक यू बोल रहे हैं पटना को चुनने के लिए. And Sandeepan, Abhijit and Sahana, they have taken pain to come to Patna to enlighten you people on eczema. Sandeepan is a known figure of eczema studies all over the world. He stands tall among all the dermatologists of India. He is known all over the world for his studies on atopic dermatitis. He is quoted in so many journals. In every World Congress, he is there as a speaker and plenary session and everything. So, thank you, Sandeepan, for taking the name of IADV to such great heights. Please give a big hand. And I'm lucky to have him as a friend for last 30 years. In 92, I still remember he was just a raw person in IADV, and we gave him BB Gokhale Award for the best paper in the PG category. And since then we know each other. And Sandeepan, I'm not that meritorious as this person. He had taken IADV and studies on atopic eczema to such great heights that I don't think there is anybody in India at least who can compare with him in the studies of atopic dermatitis. And I thank him for choosing Patna as one of his talks and venue for his Society of Eczema Studies. So I'll come three of you, Abhijit, and this young person, come to front. He is in the footsteps of Sandeepan Dhar, all the time with him, and Sahana, the youngest dermatologist and going for pediatric dermatologist, very good name and all. But Sahana के साथ एक बात है कि she is very enthusiastic, a sports person also. ये सबों को सुबह सुबह उठ के दौड़ाती भी है, घूमने भी ले जाती है, स्पोर्ट्स में भी सबसे आगे है. तो but and कल भी दौड़ेगी, but अयोध्या में भी दौड़ेगी. But then there is good about Sahana that she keeps fit and tries to keep us fit, which I am not there anywhere. And welcome you three to this Patna venue from IADV Bihar. And thank you again for choosing Bihar, Patna as it is. Thank you.
We were waiting for you to come to start the program.
अरे नहीं भाई, आप लोग की मेहरबानी है कि मुझे बुला लिया आपने. ये फोटो खींचेगा, मैं रुक जाऊँ? चलिए आइए शुरू कीजिए. मेरे को उतरने में टाइम लगता है ना, आप आइए बैठो, मैं ये बैठ जाता हूँ.
Thank you, doctors. And we express deep gratitude to IDVL Bihar branch to associate with SES as well as Ajanta Pharma. Our motto at Ajanta Pharma has always been striving to be your scientific partners and to walk us through the Ajanta Pharma initiatives. I would request Mr. Madhusudan Inamdar to come on stage. He's our cluster head for dermatology and pain management. Sir, please come.
Good morning, one and all. On behalf of Society of Eczema Studies, in association with the IDVL Bihar branch, as an academic partner, I welcome all the delegates on behalf of Ajanta Pharma. It's an honor and privilege to welcome one and all to the summit which from Ajanta Dermatology we have been propagating along with Society of Eczema. As an organization at Ajanta Pharma, I would like to give a little brief about the organization and the scientific initiatives we have done so far. I'm sure you will be interested to know. Post this particular presentation any time of the day, my team will be available in case you would like to know more about it. We are proud to say that we have been serving human healthcare need globally since 1973, completed 50 years through empathy, innovation and technology. 30 multinational, I would like to say is the nationalites who are working with us, 7,000 plus Ajantites across 30 countries. We are an Indian multinational company. We have an advanced R&D center. Proud to say that we have an R&D center which is spread across 1 lakh square feet area, 800 plus scientists working for complete value chain. We have 7 state-of-art manufacturing facilities, out of that 2 are US FDA approved one. This holds significance for all of us because our US FDA approved plant has been rewarded as zero observation report so far. Globally, less than 4% of the manufacturing facilities across the globe have been given this observation, which means till date there is a zero recall with regard to any kind of quality or batch issue. What we supply across the globe are the same medicine which is available for your patient in Indian scenario. And that's the record we talk about in terms of our quality. The remaining other manufacturing sites which are here, totally 7. We have been bestowed with various awards and recognition. Few of the prominent ones are, as you can see over here, the Young Makers of the Year from our Honorable Prime Minister Shri Narendra Modi sir, and of course the one of the giants of tomorrow from Nitin Gadkari sir, and there are few more which are there. I thought of showing couple of them over here. Not only this, we have been given or entrusted with various awards and recognition from the industry forum also. To name the few are Deloitte Best Managed Company. This was the recent one which was Golden Peacock Business Excellence Award. When I talk about the CSR activity, which is a corporate social responsibility activities, we owe it to public, we owe it to environment, and the number speaks about itself. I need not have to emphasize with regard to our corporate responsibilities what we are doing. With regard to the environment, when we talk about in terms of what responsibility we hold, this again speaks about the volumes. 7,40,000 trees are saved from cutting. Zero effluent discharge. This is the policy of green environment policy which we follow in our manufacturing facilities. I'm sure most of you must be interested in some stocks or overall as an investor also, apart from practicing. This is something which is proud, which we were able to get the highlighted in the recent economic times. Not TCS, not SDFC, 3 stocks which beats the benchmark in the last 20 years in terms of the highest returns. Ajanta features in that. It's almost to the tune of 40% CAGR in terms of the returns which we talk about, speaks about the kind of work which is happening at Ajanta Pharma. Our differentiation, we have been able to instrumental in bringing 150 new products in India. We were first as movers whenever we bring newer molecules. Our major therapy focus apart from dermatology is cardiology, ophthalmology and pain and gastrology segments. While that's about the corporate, coming about the initiatives which we have taken in the last 4 to 5 years of journey, I take pride in sharing that we have been collaborating with IIDVL in most of the activities. The flagship program which is going on and running strong still is since 2020, completed 4 successful years. So far 139 sessions have been completed. Who's Who of Dermatology has been the part of this particular online learning platform meant especially for young dermatologists. And also this has got a flip book. Anyone interested can definitely ask for this flip book. The beauty of this flip book is that it has got a QR code where all this 139 session you can watch the way you can watch Netflix or Prime Amazon movies. All 139 sessions anytime you can watch, and probably can take up in your discussion or for your studies. We have also collaborated with IDVL to conduct various international speaker programs. Our major therapy focus has been urticaria, trachology, and moisturizer. This is something which is new, and for this particular year is what is in terms of our initiative. Y Academy, we have associated with IDVL, which is for young dermatologists. So far, 4 webinars have been conducted. Couple of topics I would like to definitely talk about. PG accomplished in dermatology, what next? That's something which will be interesting for all of you to know. And that was taken up, again, Dr. Ganesh Pai and all the eminent dermatologists were there in this particular webinar. As of now, what we are tied up at Ajanta Dermatology is with SIG Dermatosurgery Workshop. So far, we have completed 2 SIG Dermatosurgery Workshop. One was in Bangalore, which catered to the need of entire South postgraduate students. We are happy to inform that SIG Dermatosurgery South had 250 plus doctors under one roof and 15 live surgeries, two-way communication they were able to get and learn from it. Thereafter, we did it in Pune at BJ Medical College. We had 350 plus doctors in this particular one-day event with 2 credit points being given. Again, 20 odd live surgeries were done by SIG dermatosurgery faculties. And I'm very happy to inform that we are now coming to East, which is happening on November 24th. Soon the letter will be given from IDVL Academy with signed by Dr. Sunil Dogara and Dr. Shonai sir, and it will be reaching to all the medical HODs. I request all the PGs to please do join for this particular event, which is going to be held at Kolkata on 24th of November. Please do mark in your calendar. Not only this, we have also tied up with Vitiligo Foundation of India. Today, while I am talking to you, one of the webinars or one of the Derma dialogues on vitiligo is happening in Mumbai as such. So these are some of the initiatives which we have done so far. For young dermatologists who are keen to know and wants to know how existing or the leading cosmetologist practitioners have set up their clinic, we started off something called as Skillhans. It's a one-day workshop. We of course are waiting for Dr. Abhishek Jha and Punkesh, where we are going to have one over here as such. But you name the eminent doctors, be it Dr. B.S. Chanshekar, Dr. Salim, Dr. Mysore Venkatram, Dr. Rachita Damishetty or Swapnil Shah, all have been associated, while in East, Dr. Sachin Verma. These are the names who are there, whom we have given one-day training program to young dermatologists. It starts at 9, ends at 5 p.m. and they get to opportunity to see 8 to 10 cases in their own clinic setup. So this is something which is ongoing, which is one of the initiative at Ajanta we have taken. Finally, coming to one which we are here, the purpose of propagating or the knowledge dissemination when it comes to eczema management. Globally, there are, what I'm told or what I'm briefed, are 7 to 8 organizations only who have in terms of eczema studies, and Society of Eczema Study under the leadership of Sandeepan sir has been prominent across the globe, and we take pride in associating with him. As Seema mentioned, prior to this we had 4 more venues where we had, and all these events were successfully attended by all the doctors. With that, I request Seema to please come and take it forward. Thank you for patient hearing. Looking forward for an extravaganza scientific event. Thank you so much. Thank you.
Thank you so much, sir, for walking us concisely through all the initiatives. Now would like to call upon the chairperson for the first session, Dr. Abhishek Kumar Jha, sir. He is the Associate Professor, Department of Dermatology from the prestigious Patna Medical College and the Director of Neelam Skin City, and Dr. Amar Kant Jha, Amar Skin and Laser Institute of Patna. Request sir to please come on stage. Along with sir, we also would like to request Dr. Vikas Shankar sir, the chairperson for the first session. Sir, please come. Again, an associate professor, dermatology from the prestigious Patna Medical College. He has 22 publications to his name, more than 50 international, national, zonal and state presentations. He is the expert committee member of CDSCO, the expert committee member of PGRC Bihar Medical University.
My program was first. They have changed the program without informing me. So I'm feeling embarrassed about it.
He's a reviewer of 3 international journals, the co-author of Manual of Rational Skin Therapy and Dermatological Drug, the recipient of Guinness World Record 2024 Brain Behind IDVL GWR attempt. He's a member of IDVL, SIG leprosy, SIG pruritus, and his special area of interest is leprosy, geriatric dermatology, pruritus, aesthetic and laser, and community dermatology. Welcome, doctors. Requesting sir to please.
Good morning,
announce.
everyone. Sahana, I'm not going to read this. You have not written, you are Joint Secretary of SCDI. National Joint Secretary of SCDI, you have not written this. Anyway, Sahana, the growing star of IDVL, and she's she's MD DNB, and she has done FR GUHS Pediatric Dermatology. She is Assistant Professor Department of Dermatology, Bangalore Medical College. She has more than 15 publications, 5 international presentations. She has 10 chapters. She is an assistant editor of IDVL Textbook of Dermatology, Essentials of Aesthetic Dermatology and Ethnic Skin, Dermatology Dictionary. She is member and fellow of IDVL, ISPD, SES. She has a special interest in pediatric dermatology, genodermatosis, pediatric Hansen's, vascular malformations. And she is Joint Secretary of ACDI also. Over to you.
Thank you, sir. So, first of all, I would like to thank my mentor, Dr. Sandeepan sir, and the whole team of IDVL Bihar, Dr. Roy sir, Dr. Abhishek sir, Dr. Vikas sir, and Ajanta Pharma for hosting me and welcoming me to this wonderful city. So today we'll talk about atopic dermatitis, particularly with respect to the Indian scenario. So I do not have any conflicts of interest. So all the photographs shown are of my own patients and consent was taken. So this is what I feel like today, standing here in front of so many eminent personalities of dermatology. So all the PGs know what GOAT stands for. So all of you know. So sir will probably wondering, मेरे को GOAT बोल दिया क्या है ये? So the GOAT is the greatest of all time. It is the short form for greatest of all time. So when we have the greatest of all time of atopic dermatitis in India, so this is what I feel like talking in front of all of you. So why exactly sir is called the GOAT? Let me explain. So I have made a list of all his publications. And this is particularly only with respect to epidemiology of atopic dermatitis. I have not even gone to other, his aspects of dermatology. This is only with respect to epidemiology of atopic dermatitis. So he started his publications from 1991, like he said, and this was the landmark study which was published in 1998. I'm sure all the PGs here wouldn't have knowledge about this. Please go and look at this landmark study. So it is called the Epidemiology and Clinical Pattern of Atopic Dermatitis in North Indian Pediatric Population. So whatever data that we have today with respect to atopic dermatitis in Indian children, everything came from this study. So they analyzed about 700 patients, children of atopic dermatitis, and before this there was no published data from India. All the data what was there was extrapolated from the Western literature. So they found that AD was increasing steadily over the past few years because of urbanization, increased awareness, smaller families, and better case detection. So the hygiene hypothesis which was there before, that rural children get less atopic dermatitis, they said that concept is not true anymore. So even though there is a slightly higher prevalence in the urban population, the rural children also do get atopic dermatitis. And they found that when it comes to the sites, the face was the most commonly involved site, followed by extensas and flexas. And they also found that infantile AD had more of an acute presentation, whereas childhood AD had more of a chronic presentation. And again, the seasonal variation is variable. Some parts of India have winter aggravation, some parts of India have summer aggravation. And also when you're looking at a child who has a cradle cap, it's very important to keep atopic dermatitis in mind along with infantile seborrheic dermatitis. Right, so again, continuation of all of Sir's publication. It goes on and on. I've restricted it to 20. Right, so we are all very lucky to be hearing from Dr. Sandeepan Dar next. So why are we specifically talking about Indians here? So we all know that Indians come under this category of skin of color or ethnic skin. So we fall under type 3 to type 6 Fitzpatrick skin. So there's a difference in the prevalence, there's a difference in the incidence, there's a difference in the disease severity and healthcare utilization, which is why it is important to study the differences between atopic dermatitis in the Western population and in Indian population. So these are a few points that I found what is different in ethnic skin or skin of color. Particularly in the Indian skin, they found pigmentation more than erythema. So it can be hypopigmentation or hyperpigmentation. Erythema is not at all appreciable in the Indian skin. And they found papular and lichenoid presentations to be more common. Whereas in Asian skin, that is Japanese, Korean and Chinese skin, it was more of psoriasiform lesions. Whereas in African American skin, it was more of annular lesions. So these are the different presentations and different ethnicities. Right, so again, this was study by Sir, grading of severity of atopic dermatitis. So they found that atopic dermatitis is much less severe in Indian children compared to the Western population. And the markers of a severe disease were male gender, a long disease duration, family and personal history of atopic dermatitis, and either early onset or late onset of the disease. Right, so again, this was a wonderful systematic literature by Dr. Abhishek De. So here they found the overall prevalence of not only childhood but also adult onset. The overall prevalence of AD in India was 3 to 9%, and the age of onset was 4 months in infantile AD and 4 years in childhood AD. There was only one study which actually showed us what is the cost for the management of atopic dermatitis. So this was the number they came up with, around 2,000 to 17,000 rupees for 6 months. And they also found depression, anxiety and ADHD to be more prevalent in children with AD. This is a very important study by this International Society study of asthma and allergies in childhood. So let me explain what the dots mean. So the red stars are the countries with high incidence of atopic dermatitis and rich countries. The green stars were low incidence of atopic dermatitis and rich countries. So you can see India falls under this blue dot. So this was low incidence and poor countries. So India falls under the fourth category where low socioeconomic status and lower incidence of atopic dermatitis. Okay, so let's move on to the clinical features. The three main points are the atopic itch, which is common to every child with atopic dermatitis, the dry skin and stigmata of AD. So coming to the area-wise distribution of atopic dermatitis, this is how it can be classified. Flexural, extensor, involvement of the face, lips, eyelid, hand dermatitis, nipple eczema and diaper dermatitis. Coming to the morphological phenotypes, this is how it can be classified. Numellar eczema, follicular, lichenoid, prurigone, erythroderma. So we'll look at photographs of each of the subtypes. So what we typically studied that infantile AD has flexural involvement, and then later as the child starts crawling there is involvement of the extensors. That need not be true. Like suppose this child had both flexor involvement and extensor involvement. So both of that can coexist in the same child, and this was a fair skinned child. So erythema is very much appreciable here. So infantile eczema usually starts with the face and scalp, and then it spreads to involve the limbs and the trunk. Whereas childhood eczema, there is more of flexural involvement and lichenification. Adults can have only persisting hand eczema or facial eczema. So here again you can see this very visible difference. This was when the child first presented. The child is in a lot of distress and crying, and even though the erythema is not very much appreciated because of the Indian child. You can see a few lesions of erythema on the face, and the second photograph obviously shows the post-treatment photo where the child is very happy and not in pain and distress anymore. So even if you're not appreciating erythema, when you see only hypo or hyperpigmentation, it's important to suspect atopic dermatitis. Here you can see this very obvious man who did not have adult onset. He had atopic dermatitis since the age of 10 years, and he had all the features of oral corticosteroid, self-medication, and abuse. Here again you can see lichenified lesions and the relative sparing of the flexus. Again, he was treated with biologicals. Right, so then let's move on to the atopic diathesis. So diathesis is a word which means disposition. So there are certain conditions which predispose us to certain diseases. So even though you may not see a full-fledged AD in children, whenever you see an atopic diathesis, it's always important to keep atopic dermatitis at the back of your mind. So there was this child who was diagnosed as a case of lichen planus. Here you can see the typical hyperkeratotic lesions, but who did not respond to the typical treatment. So when I did a dermoscopy, there was no Wickham striae, and the purplish looking lesions were typically not there. So this can be the lichenoid type of atopic dermatitis. That is a very common presentation in the Indian scenario. It's also called as the prurigo type of atopic dermatitis. So again, this is the lichenoid type of atopic dermatitis, very thick hyperkeratotic patches. So if you're seeing lichenoid lesions, but it doesn't look very typically like LP, then you have to suspect atopic dermatitis. So again, this is a very typical, the discoid rash. This is the numellar type of atopic dermatitis. Yeah, so this was a very interesting case. She was this 40-year-old lady who was receiving antiretroviral treatment. She was diagnosed as a case of psoriasis by a previous dermatologist and was given the typical treatment. But when we actually did a biopsy, the typical features of psoriasis was not there. It was more of a spongiform dermatitis. So in the literature, recent literature, there has been an overlap between psoriasis and atopic dermatitis. So we all know that psoriasis is a Th17 mediated disease, whereas atopic dermatitis is a Th2 mediated disease. They are opposite ends of the spectrum. But there are recent studies which say that both of them can coexist. So then we treated her as a case of atopic dermatitis. We started her on cyclosporin, which works for both conditions. Right, so when you see this type of a presentation, follicular lesion. So this is the follicular eczema or follicular atopic dermatitis. This is a classic presentation of juvenile plantar dermatosis, where you can see involvement of the plantar and dorsal aspects of the forefoot. Yeah, and then when you see a presentation like this, hyperpigmentation of the lips, we immediately think of the more common causes like vitamin B12 deficiency or other forms of cheilitis. But it's always important to ask for history of atopy and dryness, which leads to the condition lip lickers dermatitis. Again, when you see a scaly scalp in an infant, we immediately think of infantile seborrheic dermatitis. But if you can see here the type of excoriations that the child has caused with its nail, the severe pruritus associated with the scaly scalp, then think more towards atopic dermatitis of the scalp. Ocular features are again very important. The common scenario in an Indian patient is this periocular hyperpigmentation, that is also called as atopic shiner. And here you can see loss of the lateral 1/3 of the eyebrow, that is called as Hertog's sign. And if this is the typical eyelid eczema, and here if you can see, this child also had atopic keratoconjunctivitis. So it's very important to get an ophthal opinion whenever you see a case of eyelid eczema, because atopic keratoconjunctivitis is quite a serious condition that if ignored, it can lead to involvement of the cornea, and it can ultimately lead to blindness. So the most common features in Indian studies were the lid and conjunctival involvement. And these children are also at higher risk of ocular infections like HSV and herpes zoster ophthalmicus. So refer to the ophthalmologist whenever you see any patch of eczema on the eyelid. So all of us know that this is Pompholix, but there can be a backdrop of atopic dermatitis in these cases. And the more common presentation is this hand eczema, and we all know the apron sign, involvement of the plantar and the dorsal aspect of the hand. So this was another manifestation of ED which was recently discovered as a atypical presentation when you see excoriations in the perianal area. So this is the perianal and perineal type of atopic dermatitis. The classic fissuring and scaling that you see in the retroauricular area can be a feature of atopic dermatitis. In addition to seborrheic dermatitis, think of AD in retroauricular eczema. So here you can see this cute baby, the very obvious infraorbital denim organ fold, and you can also see the hypopigmentation around the mouth. This can be because of the constant dribbling of saliva, but you can also see a little bit of pityriasis alba here. And this is the more obvious, very extensive pityriasis alba of the face. Then whenever you see a case of ichthyosis like this, in our institution, the most common cause of ichthyosis, acquired ichthyosis, what we see is a patient of Hansen's. But when you have ruled out all the other causes, keep atopic dermatitis in the back of your mind. It's also included in one of the minor criteria for atopic dermatitis, and raised IgE is again included in one of the minor criteria for atopic dermatitis. So this was a very interesting case that we had. She was an 18-year-old girl who presented with these honey-colored crusts all over the body. It was quite extensive, and she was being treated as a case of bullous impetigo, and she was being given different antibiotics, and whenever we did a culture and a swab, there was no organism which was cultured. And after giving multiple courses of antibiotics, one day when she came with her mother had a history of asthma. So that's when we suspected atopic dermatitis, and then when we did a PCR, we actually cultured HSV. So this is eczema herpeticum, that is superimposed HSV infection in a case of atopic dermatitis. So the treatment of choice here would be oral antivirals, that is acyclovir, along with the typical treatment of atopic dermatitis. So we all know that children with AD are predisposed to infections. So viral infections like eczema herpeticum, there's eczema coxsackium also, which is an atypical form of HFMD. And here you can see multiple molluscum lesions in this child who has a lot of xerosis on his face. So children with AD are predisposed to infections, which is why some of us do give prophylactic topical or oral antibiotics, which Sir will discuss about further. Right, so this was an excellent article by Dr. Ram Gulati, the atypical manifestations of atopic dermatitis. We have discussed about all that. So all of these types are particularly common in the Indian scenario. Right, so all of us know this, the major and minor criteria for atopic dermatitis. We don't know, we can't, go through each of the minor criteria. And we also know, so this man here is the one sitting in front of us, and that criteria was the Hannafin and Raika's criteria. Sir, I found out recently that Sir knows both these personalities personally, and it would be a pleasure to hear from him next. So what we have to remember about the criteria is that a strict mathematical calculation that 3 major and 3 minor criteria is not always required. So as you see more patients, you can hardly miss a diagnosis of atopic dermatitis, and the major and minor features are only useful when it comes to research protocols. So 2 new variants of atopic dermatitis which was recently published. So one is the papular variant of atopic dermatitis, and this is the atopic labial pigmentation, which was particularly found in the Asian patients. So just look out for these features again when you suspect atopic dermatitis. Right, so the take-home points of today's lecture was atopic dermatitis is such a broad field, it's a subject in itself. The statistics are always changing, and there is more literature and research which is required from India. Indian population has lesser everything. It has lesser incidence, prevalence and severity compared to the Western countries, and specifically in Indian skin, don't concentrate more on the erythema, look out for the pigmentation and the particular phenotypes. And it's always better to overdiagnose AD. What I mean by this is when you see a case of pityriasis alba or hand eczema, it's better to give them moisturizers over a long term because they can always have a background of atopic dermatitis. So I would like to welcome all the postgraduates here to join the Society for Eczema Studies. It's the first society dedicated to eczema, and about 2 years back, we had a PG thesis grant where rupees 1 lakh was given to 3 postgraduates whose theses were selected particularly with respect to eczema. And we also have a patient tutorial corner where we upload videos of how to apply steroids, how to do wet wrap therapy. So please join the society to avail all the benefits. Thank you.
Dr. Sahana for the wonderful lecture. I request everyone to stay till the end. We have quiz for all, and we have wonderful books to be given for the winners. And I request, आवाज़ मेरी जरूर बैठ गई कॉन्फ्रेंस में बोल बोल के, लेकिन हम बैठे नहीं, हमारी टीम बैठी नहीं है. And I request you all to join us at Ayodhya. Sandeepan sir and Dr. Saha is joining us, Dr. Sahana is joining us. I request Dr. Sandeep sir also to join us at Ayodhya. Thank you so much.
Thank you, Sahana ma'am. Thank you, chairpersons, for joining. For the second session, requesting Dr. P.K. Roy sir to please come on stage. Sir is a senior consultant dermatologist, a name that needs absolutely no introduction. He has 18 publications to his name, 45 presentations. He's a life member of IDVL, IAL, IASSTD, IMA, member of EADV, International Society of Dermatology, and definitely his special area of interest has been dermatology. Requesting sir to please come on stage. We also invite Dr. Om Prakash sir, President IDVL Bihar, Senior Consultant Dermatologist, to kindly be on stage, chairing the next session. Doctor's special area of interest has been allergic reactions, atopic dermatitis, urticaria, eczema, pigmentary disorders, as well as psoriasis.
Is Dr. Sandeepan Dha, MD, DNB, FRCP from Edinburgh, Professor and Head Department of Pediatric Dermatology, Institute of Childhood, Kolkata, and former founder President of Society for Eczema, for which we have assembled here. Present affiliation is Professor and Head Department of Pediatric Dermatology. Delivers guest lecture National 320 and International 110. I must be more than that, I think, because everywhere I hear you is speaking. Number of publication National 153, International 127. Major academic achievement, author of the first pediatric dermatology book in India. Thank you very much for presenting me the first edition. I learned my pediatric dermatology from your book. Author of 5 more books and contributor 50 chapters in various national and international books. Founder President, Member Education Committee in Council International Eczema, F1000 Prime Expert on Rapid Dermatitis, London, Chairman Mentorship Committee and Member Board of Directors, International Society of Pediatric Dermatology. Recipient of Dr. Surinder Kaur Award for outstanding contribution to pediatric dermatology in India and Southeast Asia. Scientific member, SPI in France, and has chaired sessions, delivered lectures on pediatric dermatology and atopic dermatology in various important conferences in the country. May I request Dr. Sandeepan Dha to come on the dais and start his lecture. थोड़ी और तालियां हो जाए जोर से भाई, इतने गुणी व्यक्ति का सुन रहे हैं तो तालियां बजाओ. Yeah, thank you.
Thank you very much, Professor P.K. Roy, Dr. Om Prakash. Thank you very much, Dr. Roy, for all your kind words and introduction about me. Today I am going to talk about topical management of atopic dermatitis. I don't have any conflict of interest in this particular presentation. So you can make out the diagnosis. 1-year-old child with this degree of crusting, and obviously the crusting is the result of oozing. This is infected atopic dermatitis in an infantile form, which affects mostly over the face and over the extensors. However, there may be occasions where infants will also have encroachment over the flexors, as Dr. Shahana very rightly pointed out. There is nothing like that in infantile stage. Their flexural involvement may not be there. We have been seeing such cases nowadays quite often. But what is most striking is that with such kind of crusting, and you can make out there is a lot of staphylococcal colonization. What is the first thing you will do? The first thing is cleaning of the skin. And what can be the best rather than giving a proper bath to the child? So bathing is very important in our country, particularly in tropical climate. So during summer season, I often tell the parents that look, you have to give at least 2 to 3 times a day bathing. Their concern is whether the child will catch cold, because invariably child who has atopic dermatitis has a tendency to catch cold very often, and allergic rhinitis too. So you have to assure them, look, that once you give bathing with the full scalp wetting, next 2 times you give bathing, just wash the body, basically body rinsing. That's all that is needed. You don't have to give a full bath of scalp wetting. But removing this crust is very important during bathing, because this crust is the nidus of Staph aureus infections as well as other infections, which not only causes infection and can lead to extensive infection of the skin, can produce septicemia even in some untreated, neglected patients, but also it perpetuates the disease. As you all know, Staph aureus has got a super antigen type of concept. So that is how it actually perpetuates the disease of atopic dermatitis. So cleaning or bathing is of paramount importance in atopic dermatitis, particularly in climate like ours, in most of the part of India, like in eastern part or western part, where humidity and heat reigns throughout the year, apart from monsoon. During monsoon also there is good amount of humidity. Now there are 2 terms which are used, surfactants and detergents. Surfactants are basically emulsifying agents. Soap is a surfactant, and their pH should be basically, this is very important, please note it very carefully, because subsequently lot of discussion we will have around this. pH, normal skin pH is basically 4.5 to 5.5. So whatever soap or shampoo you are using, pH should not be alkaline. Alkaline pH will cause more damage to the already damaged skin. Already the epidermal barrier has gone for a toss. On top of that, you are giving an alkaline pH soap or shampoo which is trickling over the body, that will cause more harm to an atopic xerotic skin. Now, do you know about this concept? The molecule, what is the unit of soap? That is called micelle. The micelle looks like this. So it has a central core, yellowish core, what the yellow is suggestive of a lipophilic core, and peripheral is a hydrophilic core. So that means all the oil, greases, dirts, dust collected on the skin, the lipophilic part of the soap that engulfs and they washes away with the hydrophilic things outside the skin. As if with the stretched two hands, the lipophilic engulfs it or embraces it, then with hydrophilic with the stretched two arms, they throw it away from the skin. So this is how the soap works, and this is called mycelial concept. What is a soap? Soap is basically the word derived from the Roman mountain Mount Sapo, actually. So it is a salt of fatty acids produced by the process of saponification. They are the natural surfactants, as I said earlier, for washing and bathing and cleaning. Soap removes the fats and oils. As I showed, how does it remove the fats and oils? Because of this mycelial concept. There is another term which is called syndates. Syndates are synthetic detergents. Syndates has an advantage that it is better, it maintains the pH of the skin better, but at the cost of preservation. Preserving a syndate is difficult, right? So, both has got merits and demerits, soaps and syndates. Nowadays, the current days concept is using syndates, various syndates, right? So, the syndates are definitely advantageous in terms of restoring the pH of the skin, but over a long period of time, preserving it is a challenge, but people are working on it so that it can be preserved over a long period of time also nicely. As I said earlier, I shall be coming to that. So now I have come to that. Do you know what of the most of the soaps claim to be, which you see on TV screen or magazine or film magazine, and the various film stars are advertising, not knowing even how many layers are there in the skin. They are advertising which is best for the skin. Very unfortunate situation, and only probably happens perhaps in India only, India and subcontinent. So the responsibility is given to those who do not know anything about that. So it happens everywhere, not only in dermatology. So they advertise something, some soap, and their pH is 7 to 9, highly alkaline pH. All these soaps which are available in the market in the name of baby soap, very safe soap, not produced by the pharmaceutical company, even by some pharmaceutical company who don't come to us, who go to the TV and news channel and magazines and newspapers for marketing their products. So there was a nice paper published in IJDVL by Dr. Gulrez Taib Khan from Mumbai, and she very categorically showed that all these so-called soaps in the market, say for example baby soap, so-called some companies baby soap, glycerin soap, blah blah blah, they all have a pH which is alkaline pH, which is deleterious for an atopic skin, otherwise also for a normal skin also. And pH of the soap, not only it damages this skin and makes it more dry, and the epidermal barrier defect is also more injury occurs to that. There is more bacterial flora colonization occurs because of that as a complex mechanism. Now coming to how do we restore the dryness of the skin. The dryness of the skin is restored by emollients or moisturizers. By and large, we use the term emollient and moisturizers interchangeably. And as far as BNF, British National Formulary, there is hardly any difference between these two. But as far as United Nations Pharmacopoeia, US Pharmacopoeia, these two are different. So emollients are the lipids that occlude the skin surface, thus preventing the water loss from the stratum corneum. So basically they maintain a layer on the skin. And moisturizers, they are the lipid emulsions that actively hydrate the skin by application of a humectant which goes inside the skin, as well as they prevent the water loss. So moisturizer is probably more comprehensive in restoring the transepidermal water loss. They penetrate the water inside by their humectant nature, as well as they maintain a seal outside the stratum corneum, thereby prevent the water loss. So emollient does just the sealing effect. So moisturizer term is probably more important and comprehensive and correct scientifically. It is basically a generic term. It encompasses number of substances. You will see most of the moisturizers, they contain number of substances. And they are not a single substance. So all these substances together, they maintain the moisturization of the skin. Let us look at some of the substances. There are different classes of moisturizers. One is emollient dominant type. Emollient dominant type is basically used for typically making the skin soft, and this is more for aesthetic purpose. It contains mineral oil, lanolin, oleic acid, linolenic acid, linoleic acid, and linolenic acid. Then humectant based. Humectant based is suitable for maintenance of skin conditions. This is oil in water emulsion. That means it is more greasy, and ingredients are glycerin, sorbitol, lactic acid, carnitine, serine, alanin, lysine. You will see many of the moisturizers contains these substances. I am sure that many a times you have just wondered, what does this individual substance do? This individual substance do exactly what it is written over here. Now the occlusive protective type. This is water in oil type, ointment type basically, more greasy again. See, this restores the barrier function, like beeswax, petroleum, petrolatum, dimethicone, olive oil, jojoba oil, all these things they make. There are so many types of moisturizers. Many a times our colleagues in other specialties think moisturizer is a single term. Why the dermatologists, they split their hair like that? So they need to be told that, look, moisturizer for face, moisturizer for a baby, moisturizer for very scaly, thick scales of psoriasis versus very thin scale, dry skin of atopic dermatitis. They are all different types. So they cannot be clubbed under one single blanket statement that this is the moisturizer you apply for every condition. No. It has to be tailor-made. Now the therapeutic moisturizer. Basically it is formulated to treat diseases of skin conditions with a xerotic background and composition of multifactorial ingredients that protect, hydrate, and support endogenous barrier. So what are those? They are emollients, occlusive, humectants, NMF, and ceramides. So ceramide, actually addresses the filaggrin gene mutation defect. So for very severe dry skin, you need a ceramide moisturizer. In fact, it may so happen, I have many such patients, many such children, where I write a separate moisturizer for the trunk and another moisturizer on the face, because the child has a differential skin and the degree of dryness is different. I shall show you a picture of such a child. Some of the important moisturizers in Indian practice are vegetable oils like coconut oil, olive oil, groundnut oil, peanut oil, or sunflower oil. Then oat. Oat is a very good moisturizer. Please do remember. And it can be used during acute flare of atopic dermatitis. Liquid paraffin, it is viscous and thick, and that's why it may not be very acceptable, but it is a cheap moisturizer. Then urea. 3 to 5% urea is very good for palms and soles and hands and feet, but maybe irritant for acute flare during eczema. So better to avoid that. Once it subsides, then start using it. 6 to 8% of urea is keratolytic. Fragrance and paraben. See, we often theoretically talk, in moisturizer, paraben and fragrance are strictly no. Let me tell you, from my experience as well as from experience of International Eczema Council's global leaders in atopic dermatitis, in which I am the academic committee member, we do not believe that fragrance and paraben by and large in practically does anything bad, or there is so much hypersensitivity incidence. No, practically it is not so. Rather, the small children, they accept it better, to be very honest and to be very practical. How do you use moisturizer? With just a recapitulation, which we all know, within first 5 minutes of bath, because that time the stratum corneum is hydrated, policy should be, uh, variable according to the geographic location. As I said, in a humid area, you need not apply moisturizer all over the body. In our country, I have been telling it for last 30 years, not only in India, all over the world, that in our country, use of moisturizer is basically on the hot spots, just like you apply steroid, then apply moisturizer, or more importantly, first apply moisturizer, then apply steroid. Don't apply moisturizer paint just like they do in Scandinavian countries or in US or UK, where most of the time it is very cold. So in our country, if you apply moisturizer over a wide area of the body, that will lead to not only uneasiness or sticky sensation, but lot of development of secondary bacterial infection, particularly folliculitis, because of occlusion. So concept of application of moisturizer will vary depending on geographic location of your patient. So no one single strategy should suit for all patients. So like for example, as I said, this child for trunk, I used a moisturizer which is fairly good enough, but there was no need of any ceramide containing moisturizer. But for the face, apart from mild topical steroid initially followed by topical Kisaborol or Pacrolimus, moisturizer which contains ceramide is always better. So many patients, I give two moisturizers, one for the trunk, one for the face, one for the trunk, one for the limbs. So there is no hard and fast rule that one single moisturizer you have to apply for all areas of the body. Criteria of an ideal moisturizer: safe, simple, effective, steroid sparing, intrinsic anti-inflammatory action. So this is what written in the book. But something which is not written in the book comes from the practice, right? So what is the best moisturizer? The moisturizer which the patient and the parents like most. They say that, doctor, my child is very comfortable with this moisturizer. Don't ever contradict, I am telling you. In practice, many a times you have to just go by what the parents feel, and this is not compromise. This is basically, nowadays there is a terminology has come, shared decision. The old days concept of practicing and preaching to the patients has changed. Now you are not sitting on the other side of the table. Do this, do that. No, nobody is going to listen to you. They will go to the Consumer Protection Court. Right? So you have to have a shared decision. If the patient says, doctor, I am happy with this moisturizer, say, okay, fine, you apply. Otherwise, what will happen, I am telling you, from my practice, you have given the moisturizer which the parents were using much better moisturizer. This is a fourth class moisturizer, fourth grade moisturizer. But suddenly the child developed acute fear during that period because of some other reason. And the parents will immediately come back to you, doctor, you changed the moisturizer, I told you, na? And immediately see what has happened to my child. So whatever happens, they will accuse you of that, right? So you have to keep these things in mind always, that something when the parents are happy with, don't try to change the protocol of treatment, not only in case of moisturizer, but in case of many things. So there are certain fundamental questions. Obviously, our patients and parents of the children, they ask that how much should be used, which one should be used, how frequently should they be applied, where they should be applied, this moisturizer, when they should be applied, how it should be applied in relation to topical steroid. This is a very common question. Doctor, whether to apply topical steroid first or moisturizer first. So this is the question very commonly faced. I am sure many of you have that question. First, we should apply the steroid or the moisturizer. Here is the answer. I am coming. For acute exacerbation, you should use a greasy moisturizer, right? So for maintenance treatment, right, you have to use a light moisturizer because acute exacerbation, there is a lot of oozing and other things. So you have to control the oozing. When you are using an emollient or moisturizer as well as steroid, you should apply first steroid, then after few minutes, first emollient or moisturizer, after a gap of few minutes you apply steroid, so that there is no extra absorption of the steroid into the system, particularly for small children, which is very, very important. I shall show you a steroid painting was done in a 6-month or 7-month-old child, and how the child developed iatrogenic Cushing's. I will show you some pictures which I have seen in our Institute of Child Health. So this is the guidelines, not by me but by NIH in 2015, and this is followed all over the world. So how moisturizer is effective? They replace water lost from the skin, lubricate the skin, reduce scaling, and they seal the stratum corneum. Now, moisturizer is extremely important as far as atopic dermatitis is concerned. It prolongs the time of flare, as well as it has got a preventive role in atopic dermatitis in small children. It has been seen if within few weeks of birth in a high-risk child for atopic dermatitis, if you start moisturizing, then either development of atopic dermatitis is delayed or atopic dermatitis does not develop, and we talk about it as a preventive treatment for atopic dermatitis. And there are a number of studies all over the world. I have picked up few very important studies. This is another study which talk about the same thing. Emollient alters the skin barrier, not only barrier but microbes also, as I told you earlier, and the risk of developing atopic dermatitis becomes less. How do we treat atopic dermatitis? At different stages, as it is shown here in this beautiful diagrammatic representation. The dryness is counteracted by moisturizer. Each is addressed by antipruritic, and inflammation by steroid topically or topical immunomodulators. So this is atopic dermatitis. Its course is punctuated by recurrent remissions and relapse. So the relapses are called flares. During flare, the control of the disease is the most challenging. There lies the real challenge for treating atopic dermatitis. And the day one the child is brought to me with an atopic dermatitis, I tell the parents, I do good counseling, I spend extra 25 minutes time. I tell them that please be prepared for a long drawn battle for next 5, 6, 7, 8 or 10 years. This is not a disease which is going to go in few months. Once you do counseling properly, let me tell you, the patient won't change you, patient won't go to another doctor. Most of the time what I have heard, we have never been told these things. So it is better that you tell them on the very first day that I am not there to show you some magic. I am there to give you the guidance as per scientific knowledge and current day practice. And you have to bear with it and have patience, and on long-term treatment you will get response. Whether you give cyclosporine, whether you give JAK inhibitors, whatever it is. On the very first day, this counseling is very important. As I always say, the treatment of atopic dermatitis starts with moisturizers and it ends with counseling. So these are the various topical steroids. You all know, just a recapitulation. Potency wise, I have put them in a list like this. You can read it out to save some time, so that we have got many more things in the pipeline, panel discussion and many other things. So we give a very mildly potent steroid to the babies. Certain things about use of topical steroids I am going to speak next. Topical steroids should be applied at most twice a day. Please tell these parents repeatedly. Give some example. I give example. that सब्जी जब बनाते हो, नमक जब कम लगता है, नमक देते हो ना? बोला हाँ. कितना बार देते हैं? बोले एक बार. क्यों? 2-3 बार देने से तो और टेस्ट बढ़ेगा ना, नहीं नहीं जी वो तो एकदम बर्बाद हो जाएगा। ऐसा ही मलम भी ऐसा ही लगाना है, दिन में 10 बार लगाओगे तो स्किन बर्बाद हो जाएगा। डोंट अप्लाई मोर देन ट्वाइस। इफ यू टेल देम दिस फॉर द लैंग्वेज दे अंडरस्टैंड, they will immediately understand it. This particular piece of advice is for housewives, right? Then once a cab driver came to me with a child with atopic dermatitis. I was trying to explain to him, so not to apply steroid too much. I told him टैंकी फुल करने के बाद भी पेट्रोल डालते हो? नहीं नहीं नहीं, वो तो बाहर निकल जाएगा और पैसा भी निकल जाएगा। फिर ऐसा ही करना है, जितना लगाना है उतना है, उससे ज़्यादा नहीं। तो इन हिज लैंग्वेज ओनली। सो यू हैव टू एड्रेस, काउंसलिंग इज द आर्ट, प्लीज डू रिमेंबर। एंड बिफोर काउंसलिंग यू मस्ट नो द प्रोफेशन ऑफ द पर्सन। The person, the profession of the person is important because your language should be accordingly tailor-made for that person. This I do very carefully, and all my clinic staffs, they know it. They enjoy it also, and they know it also in what language I am going to speak to that person. So, as much as small amount as much as possible should be applied, not too much. Many times they apply ointment like a butter on the bread. That has to be told. Don't apply ointment like a butter on the bread. You have to apply or smear just like a cold cream on your face, right? Avoid steroid combinations. This is very important. So these are some of the considerations for choosing a topical steroid. These various factors which decides about the selection of topical steroid. This is a wonderful list of that. It depends on the potency or class of steroid, then type of dermatosis, extent of dermatosis, duration of topical steroids, usage, location of dermatosis. It may not be the same over the face as well as over the extremities. It will be different. Then usage in infants and children, and state of the epidermis. Because in infants, very small infants and infants and small children, the skin surface area and body area ratio is different. So there is lot of chances of absorption if you apply over large area of the body, particularly a moderately potent steroid. What happens? We'll see. So fingertip unit, all of you know, but in practice we actually don't do it. After 5 years of post-MD, I think we have got enough experience to diagnose atopic dermatitis. Sahan has showed Hanifin and Rayaka's criteria. It is the gold standard for diagnosis of atopic dermatitis. Even after it was first described in the year 1980, it came in the journal Acta Dermatology Venereologica, volume 48, page number 47 to 71. So this is, I have written more than 1,000 times in various articles. That's why I remember each and everything about it. So Hanifin and Rayaka's criteria is basically for academic purpose, for thesis. You are doing thesis for research purpose, for clinical trial purpose. But in our practice, day-to-day practice, any dermatologist after post-MD 5 years of experience does not need Hanifin-Rayaka's criteria to diagnose atopic dermatitis. You can simply see and make the diagnosis clinically. Similarly, you don't need a fingertip unit to calculate this. You roughly tell the parents that this much amount of steroid should be applied. One tube, एक tube इतना दिन चलना चाहिए क्योंकि बच्चे को इतना है eczema. So roughly you calculate and tell. Don't use more than that. So this is the necessary estimation of topical corticosteroid, face, neck, arm, as you can read it out from this list, depending upon the age of the baby. Important tips for topical steroid use. These are important, extremely important. These are very basic, but these are very important. I am telling you, even in the days of all hi-fi things like dupilumab, abrocitinib, many times I have seen many of our colleagues, many of our students, many of our junior colleagues, they do not know much. They are not very much clear about the use of topical steroid or use of tacrolimus. So as I already told that how steroid should be used, this is very important. When the disease is under control, go for intermittent steroid, topical steroid. And all said and done, please do remember, till even today also, topical steroid remains the number one treatment for atopic dermatitis anywhere in the world. Even if you are interested, you will see the abrocitinib trials, Z1, Z mono, then Z extend, Z regime, all these trial. Recently what they have tried, what they are trying all over the world, because all these people who are doing it, my colleagues and friends in International Eczema Council, so they are doing now combining abrocitinib with topical steroid, TCS. So in between you are giving TCS. So you cannot go away from topical steroid and moisturizer while treating atopic dermatitis. Just to show an example, how does mild steroid like Dezonite work? Within 2 weeks it clears the eczema completely. This was the unfortunate 6-month-old baby who had infantile seborrheic dermatitis, and some of our pediatrician colleague applied steroid, and the parents, this was not pediatrician colleague's fault. The parents, they started just like I told, namak kaise use karna sabji mein. They thought that it is clearing, so let us apply more and extensively all over the body. And within few months the child landed up with iatrogenic Cushing's. And when we checked the serum ACTH level, it has gone for serum cortisol level, it has gone for a toss. So another baby. This is not uncommon. These are all seen in our Institute of Child Health, where me and Dr. Abhijit Shah, we work together. So combination of steroid and antibiotic. So it is only useful for localized infection, right? Localized eczematous lesions over the anterior nares, external auditory meatus. For extensive bacterial infection, you give oral corticosteroids and topical moisturizers. So don't use topical steroid and antibiotic combination. Like this, you get good result with steroid antibiotic combination, but for limited period. Is there any steroid resistance? Many of my younger colleagues and students, they ask, sir, is there any steroid resistance? I say that whenever you feel that there is steroid resistance, you must check few things. Whether the compliance of the parents is good, they have been properly applying steroid. Whether there is any history of under treatment, they have not at all applied, and they are saying the doctor, after application of this, nothing is happening. Then sudden reduction of the potency. They have themselves reduced the potency suddenly by the biggest doctor. Biggest doctors are who? The pharmacist in the medical shops. They say the doctor ने antibiotic augmentin 3 बार करके दिया, क्या जरूरत है, 2 बार दे दो ना, 7 दिन. So they actually skew your prescription, modify your prescription, and the people somehow they believe, trust at times more. So that's why we need counseling. Then sudden stoppage of topical steroids. There's another thing is topical corticosteroid phobia, which came up in 2000. This is very interesting. Please listen very carefully. In 2000, by none other than Professor Hyle Williams, father of evidence-based dermatology, or father of dermatology Cochrane database of dermatology in the world, and his team. And interestingly, when the people have developed steroid phobia in this society, in the Western society, people were searching from another molecule which is equally effective but is not steroid, does not have the steroid adverse effect like steroid. And in the same year, in the 2000, topical tacrolimus came in the market. US FDA approval came in the year 2000. So I always say, showing up these two slides, so in God's creation, as we always say, when one door closes, another door opens. When the people have developed steroid phobia, already God has supplied non-steroidal molecule for the patients of atopic dermatitis. So topical tacrolimus came as a boon for long-term maintenance treatment of atopic dermatitis, for which cannot be done with steroid. You cannot give attestage for 5, 6, 7, 8 months or interruptedly for few years, 5, 6 years. We did the first study of topical tacrolimus in India, we published, and that was with just 15 children. You ask me why? Because all these parents who brought their child were NRI, and they got the original molecule of topical tacrolimus by Fujisawa of Japan, protopic. Each tube used to cost 1200 rupees, and you cannot buy one. You have to buy a box of 10. 12,000 rupees, those days in 1997-8 I am talking about. So, before tacrolimus was US FDA approved, we carried out the study, though we published late because I didn't find someone like, Abhijit and Sahan at that time to write it fast. So, we found there is good amount of improvement with topical tacrolimus. And also we have recently published an article, meta-analysis of the data of long-term topical tacrolimus, a systematic review and meta-analysis of intermittent use of topical tacrolimus for 3, 4, 5 years, and it is very safe. Some of the newer molecules I will finish in next 3 to 4 minutes. Like JAK inhibitors, we have authored an article along with Abhishek, me and others, Kiran Godse and others, in Indian Journal of Skin Allergy. Here I must say, Indian Journal of Skin Allergy is a joint venture of Society for Eczema Studies and Skin Allergy Society of Dr. Kiran and Dr. Abhishek De. So this is the journal dedicated to eczema and urticaria and contact dermatitis, all types of allergy. And this is the only journal dedicated to allergy from Asia, let me tell you. So all those who are interested to publish their any thesis or work on allergic disease, please publish in this journal, because the reason is in future there is high chance of this being quoted in textbooks. So we have written a review article in our IJDVL very recently about the role of JAK inhibitors in atopic dermatitis. I won't go into detail because during panel discussion, I am sure that Dr. Abhijit Shah will ask the related questions, and we should have enough time for panel discussion. Some of the newer molecules I highlighted here. Topinaraf is a new molecule which is aryl hydrocarbon receptor inhibitor. This is already being used in psoriasis. This is also being used in atopic dermatitis in several phases of trial. Crisaborole. Crisaborole is a very exciting molecule nowadays available in Indian market as 2% ointment. Only thing, cost is a limiting factor. But by and large, the kind of irritation potential we used to believe, I also used to believe earlier. Of late, I have not been seeing that much of irritation with this. In fact, we have published in Indian Journal of Skin Allergy, Crisaborole efficacy, a 4-week trial in pediatric atopic dermatitis. Topical tofacitinib has also been recommended. The articles have come. In British Journal of Dermatology, Robert Bissionet was the past president of International Eczema Council, a friend and colleague of mine from US. US FDA has approved, ruxolitinib for topical use of atopic dermatitis. Currently, it is exorbitantly costly. Oplezura, as it is named internationally. But let me tell you, some companies are working on it, and soon it will come in Indian market, and like tofacitinib, it will be very cheap. This is the last slide, last scientific slide. Please look at this, which has come just last year in the list of strength of recommendation level of evidence, which stands at the top, use of moisturizer. So as I told you, the treatment of atopic dermatitis should start with use of moisturizer, it end with counseling. You see, in spite of all other molecules, cyclosporine, blah, 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 all these things, even the dupilumab and abrocitinib, moisturizer tops the list in strength of recommendation and level of evidence. So just like puja cannot be without an agarbatti and candle or light, so no atopic dermatitis can be treated without moisturizer. Please keep it in mind, engraved. So voting is on. I am sure most of you have voted by this time. Even if you have not, please vote for Kolkata, because you know it is after all the unity of Eastern Zone.
Those who were voted.
Th-
Any more thanks?
Thank you very much for your
Okay.
patient hearing.
Thanks, Sandeepan Da. A very good lecture from you. Have you any query from audience?
We'll have panel discussion, sir.
Okay. Okay, thank you very much.
Yeah,
Thank you.
Thank you so much.
Thank you very much. Thank you very much, sir.
Thank you so much, sir, for a wonderful session, and I'm sure it has a lot of learnings for all of us. Next, I would like to call upon the moderator and the quiz master for today, Dr. Abhijit Saha, sir. He's coming from the cultural city of Kolkata. His present affiliation is Consultant Pediatric Dermatologist, Institute of Childhead, Kolkata. He has 37 publications to his name, numerous presentations at local, state, and national level, authorship in 16 chapters. He is the recipient of Professor Salil Kumar Panja Award for Excellence in Dermatology 2023, the Bishnu Priya Devi Award 2023 for Best Original Article in IJDVL, second in IDVL GSK Quiz State Level 2013, and third in the award paper presentation in West Bengal Cuticon of 2012. He is the member of IDVL ISPD SES, the International Society of Pediatric Dermatology, reviewer of IJD IJSA, Indian Journal of Pediatric Dermatology, Indian Journal of Postgraduate Dermatology, and his special areas of interest are in pediatric dermatology, atopic dermatitis, dermatophytosis, and neonatal dermatology. Welcome, Dr. Abhijit Saha, and the quiz master for today, and he'll be walking us through the interesting and difficult quiz which is coming your way.
We have our esteemed panelists with us, so you can see their CVs. Dr. Ravi Vikram Singh, Director and Chief Consultant, Vikram Skin Clinic, Patna. He was a Dr. U.K. Pallavi, Assistant Professor, Skin and VD, Indira Gandhi Institute of Medical Science, Patna. Dr. Svetalina, Associate Professor, Department of Dermatology, AIMS, Patna. Dr. Dheeraj, Director at Dama Web Skin Laser and Hair Transplant Center, Patna. And obviously our two esteemed speakers, along with Dr. Ashutosh Ranjan, Consultant Dermatologist from Saran. So we have a quite rich panel with us. Seema, how much time is left?
Just about 5 minutes more for the quiz to get over.
To give as much, as many number of right answers as possible. Good afternoon, everybody. Hope you are recharged right now. So just we are about to start the exciting panel. First of all, where is my presentation? इसको बंद कर दो हाँ रुको रुको hold it. So at the outset I want to express my sincere thanks to Sandeepan sir, Bihar IDVL branch, and obviously Ajanta Pharma for having me here. It's a wonderful afternoon, and I am fortunate to have such a erudite panel with me. So, without further ado, I would like to request my esteemed panel to please come over the dais. Obviously, Professor Sandeepan Dhar, Dr. Sahana P. Raju, Dr. Ravi Vikram Singh, Dr. U.K. Pallavi, Dr. Svetalina Pradhan, Dr. Ashutosh Ranjan, and Dr. Dheeraj Kumar. Please come over the dais. And also I would like to request all the dignitaries, all the delegates present here to please actively participate in this conversation. I always believe in dialogue, not monologue, and it should be interactive session. This is the learning curve. We are all in this learning curve. So please feel free to ask question to our esteemed panel, and even you can put forward your thoughts, your insight. You can share your own views regarding during this discussion, so that we can learn from each other, and at the end of the day we can go back with maximum number of takeaways. Please arrange one chair. So guys, are you ready? Some vibes please. Are you ready? Louder. Are you ready? Yes. So we are going to start a vibrating quiz, a vibrating panel discussion. It should be very interesting, absorbing, and enthralling, I would expect. And that's why I'm repeatedly requesting you to actively participate and interact. If you want to share anything, just raise your hand. I will go to you. Don't worry. We have a lot of cordless microphones with us. Uh, so just look at this child. I mean, AD is just like a child, or on the other way around, you can consider this. Can you see it? Can you see the questions? So we can huh? স্টেজটা উপরে করে দেবেন হবে? তাহলে করুন, একটু একটু তুলুন। পয়সা ले लेंगे। So is it visible properly? Yeah? We have adjusted We have adjusted? Yeah. So, look at this child. Eddie is just like a child, or as I said, on the other way around, you can consider this little child as a living replica of Eddie. See how happy and cheerful he is, just like Eddie in remission. Now mood is getting changing. I mean, something is cooking up in the mind. You might need to call for some extra help, or you might need to talk with the baby, rhyming, playing, etc. Just like very mild topical immunomodulators like pimecrolimus or crisaborole in atopic dermatitis. Now the mood is really deteriorating, and if you don't put some extra effort, the child may burst into tears. Here you need to call for extra help, call her mother, call his mother, call his grandmothers, just like some strong immunomodulators like topical steroid in atopic dermatitis. And this is the extreme condition. I mean, you need to exhaust all your available resources from cyclosporin to immunomodulators, everything. And for this baby, obviously you need to exhaust all the resources like his toys, gadgets, everything. But thank God, the smile is restored, untinted. And please remember, no matter whatever resources you use, no matter how much effort you put in, the basic fundamental care for a baby remains the same, be it love or affection, just like moisturizer in atopic dermatitis. And thanks to my son Avigyan for allowing me to use his photographs. So with this, let us start our serious discussion. So first question, I shall start from extreme left. Ma'am, what do you feel? Do you feel that prevalence of AD is on rise?
Hello. Good morning, everybody. I feel so because nowadays we are seeing more patient coming with the from urban cities because of their lifestyle and their food habit. They have changed. They have more westernized. They are using more means common places like swimming pool and repeated hand wash. After COVID, they started using frequent use of sanitizer. Still, people are using this one.
So you think there are several reasons for this? I mean,
Yes.
prevalence why it is increasing. Yes, Svetalina, what do you feel?
I also agree. The number of atopic dermatitis cases are increasing on rise. And previously, we used to see atopic dermatitis when winter used to come. Now we are seeing throughout the year atopic dermatitis cases.
Sir, your take on this?
I agree with my two co-panelists. I will add one more important point why this is on the rise. The broken family system is one of the major factors. I have seen children where both parents are working and the child is left in the care of a maid or nanny. And that person who is supposed to take care is more involved in the mobile talk and all those things, and the child is left alone. He feels desperate and helpless. That feeling of desperation and helplessness and that increases the stress level, and that increases the prevalence as well as severity of the cases.
Please keep silence in the auditorium. Don't talk on your mobile. If you have any emergency call, please go outside and take the call and then come back. Yes, sir. Definitely, these are valid points. I do agree. Yes, Dr. Ashutosh?
I would like to add few points, like apart from increased urbanization, food habits, like we are using more of processed foods, and environmental changes these days due to warmer climates.
The situation is not the same as it was 20 years back. according to SAR's thesis, right? SAR's study. So there is an increased rise in prevalence. Yes, Dr. Dheeraj, do you see more and more number of severe cases nowadays?
Definitely, prevalence of it is increasing, but severity in few cases, like in developing countries, severity is also increasing. In developed countries, there is definitely a plateau has arrived. The incidence is decreases, but in developing countries like ours country, severity of disease is increasing.
Severity also increasing, na? You are getting more and more number of severe cases.
Yes. Especially in infant and child.
Infant and child. Sir, your take on this?
Severity and prevalence and severity both are increasing over last 22 decades. The reason being all the factors which have been very nicely pointed out by my co-panelist. Earlier, when I was doing my thesis on atopic dermatitis way back in 1989 in PGI Chandigarh, Staph aureus colonization in atopic dermatitis. That time we had only topical steroid and moisturizer and antihistamines to treat, and we could control 99% of the atopic dermatitis patients. I don't remember a single patient whom we could not control. But during, after 10-15 years came cyclosporine, then methotrexate, started being used in atopic dermatitis. Mycophenolate mofetil came, azathioprine, was used. So a time has come now. Even with these molecules, we are not able to control. 10% of the patients we are not able to control, and that's why biologics, small molecules like abrocitinib, like dupilumab biologics, all these are coming, and more molecules are coming up, and this is a global phenomena. In fact, the incidence, when we did the first study, which Sahana highlighted way back in 1994, so that time the incidence was approximately 4% in India. Now incidence is approximately 10% in India. Now approximately 25 to 30% patients fall into the category of moderately severe to severe atopic dermatitis, but 2 decades ago it was only 5%. Now approximately 10% of the patients fall into the group of very severe atopic dermatitis who cannot be controlled by conventional immunosuppressives, and they will need either biologic or small molecule to control their disease. So this is the picture, and globally also picture is the same. The incidence is probably more in different countries, but severity is also, their severe atopic dermatitis severity scale is much more than our severity scale by and large. You have to remember. The incidence in atopic dermatitis amongst the Western countries, some of the figures I must tell you. In UK it is 22 to 23%, in USA it is 25%, in Scandinavian countries, that means Denmark, Norway, Sweden, it is between 27 to 28%, and among the Asian countries, the highest incidence is seen in Japan, Hong Kong, Singapore, and Korea, South Korea, right? So this is the kind of picture all over the world.
So very valid point actually. This use of these so-called very strong immunomodulators, we have to actually, we are forced to exhaust almost all our armamentarium. Previously cyclosporine used to do well. Now we have to search for dupilumab and abrocitinib. These are the indirect evidences that severity is really increasing. Yes, Sahana, you want to add something on this point, or I should shift? Anything to add?
Just one point, sir. I feel the prevalence is also rising because of better case detection techniques.
Yes.
And better awareness among pediatricians and GPs about atopic dermatitis.
That's what my next question is all about, because probably in few years back, 20 years back, we could have missed those uncommon presentation. That's why probably that is another reflection why we used to get a lesser prevalence or less severe cases of atopic dermatitis.
Comment here, Abhijit.
Yes, I'm coming, sir. For the next question, that's my next question. So again, I shall start from extreme left, ma'am. So if it is so, I mean, if the severity is increasing as well as the prevalence, what are the different morphological forms? What are those uncommon presentation you are seeing nowadays, except those classical flexural presentations? Or
Nowadays, patients are more coming with hand and foot eczema or dermatitis. Then follicular atopic dermatitis presentation is also there.
Setolina, uncommon presentation?
Like eyelid, frequently eyelid dermatitis. Like Sahana showed exfoliatic cheilitis like presentation. This is a very frequent presentation nowadays. Fissuring at the finger and toe tips. Then lichenified, single persistent lichenified plaques above the extremities. So these are maybe sir can.
Sir, you want to add something?
Yeah, basically, Dr. Sahana had showed the photos also and enumerated. I will just like to repeat
but
that.
We need to reiterate the facts again so that
right.
we can get
So,
back with some
follicular erythema and prominence,
follicular erythema,
basically over the trunk, where the parent might say there is no eruption with itching, but there is no eruption once, but you examine carefully, you will find it, especially over the trunk. Then lichenoid sort of eczemas, psoriasiform dermatitis in setting of atopic background. Then hand-foot eczemas, perioral dermatitis,
perioral dermatitis, absolutely,
and sometimes ichthyosiform areas on the background of. Then there is something also reported as toilet seat dermatitis.
That I will come to.
Right.
Yes,
so
Dr. Asutosh, you want to add something except this
I think
presentation?
almost everything has been covered.
You can share some story also. That will be very easy for us to remember. Any case you initially initially struggled, then kind of, if you have any.
The same case Dr. Sahana has discussed. I treated a patient as lichen planus hypertrophicus, and later on it was atopic dermatitis.
That is a very interesting one. Yes, Dr. Dheeraj, you want to add something?
Perianal and genital
perianal rash.
atopic dermatitis, which is actually generally spared in atopic dermatitis, but nowadays we can see a few cases of perianal. One nummular dermatitis, one case was nummular dermatitis, who frequently come to us with some relief after topical steroid application. So on detailed history, we see that her family history was also having atopic dermatitis and asthma.
So we have to keep our tentacles very high. Actually, as Sir said, every time you cannot fulfill the Hannifin-Rajkas criteria, but if you, as also Shana also said, if you continue seeing the patients day in and day out, definitely will grab this uncommon presentation. Yes, sir, your take on this.
Atypical entities have been covered. And just a couple of things I wanted to add. One is atopic vulvovaginitis. It's underdiagnosed conditions. Many small children, lots of pinworm therapy is given by the pediatricians. Itching is not going, and over a period of time, they develop lichenification. Even yes. I have seen 6 months old, female child developing lichenification. These are nothing but atopic vulvovaginitis. Similarly, counterpart in male, atopic sphenoskrotal dermatitis.
Yes.
So like perianal dermatitis, atopic sphenoskrotal dermatitis. These are some of the other forms of atopic dermatitis or unusual forms of atopic dermatitis.
Dr. Shahana?
So that's it. Even when there's a case of erythroderma, we should always rule out
erythroderma,
atopic dermatitis.
AD should come as differential. So
even in adults.
These are few of my experiences, obviously with Sir in Institute of Child Health. The pictures are self-explanatory. You can see these are different kind of presentation we used to get. Lip-leak dermatitis is not uncommon in AD patients. And diaper dermatitis, according to the conventional teaching, diaper dermatitis shouldn't occur in diaper area for the simple reason because it is occluded, it is moist and inaccessible, not amenable to itching. But on the other way around, some uncommon presentation may occur, may it start from a diaper area also. Isn't it, sir?
Yeah, it is true, but there are two things I just wanted. Yes. And there are two things I just wanted to highlight. One is, we call it lip leakers dermatitis. basically we must remember that normal child, do they develop lip lick dermatitis? Many child will lick the lips. It is only the atopic child. They have an, underneath atopic cheilitis. Because of irritation, they start licking it, and because of licking it, it spreads because of saliva, irritation by the saliva. So by and large, lip lickers dermatitis or lip licks dermatitis, all cases are atopic dermatitis, nothing else. It is not a separate entity. This is number one. And number two, nummular eczema. This I have been telling for last 30 years. Nummular eczema is nothing but atopic dermatitis. What other causes nummular eczema is there unless and until there is a clear evidence of contact dermatitis because of wristwatch band or something like that, or any metallic object. Is there any other cause of nummular eczema? Just think yourself. A nummular eczema in a child is atopic dermatitis. There is no other etiology of it. When we see a single plaque of psoriasis, do we call it nummular psoriasis? It is psoriasis. So it is better to be called as atopic dermatitis rather than nummular eczema.
So you can get this kind of picture also, head and neck dermatitis. A simple course of itraconazole will do. As sir said, penoscrotal fissure or dermatitis, retroauricular fissure already shown by Dr. Sahana. Breast or nipple eczema is uncommon in pediatric age group. Please remember, you can get this kind of frictional lichenoid dermatitis, scalp eczema. This is what sir has already spoken about. You can see this lichenification in the small child. Such a small child can also scratch. So don't get confused. Follicular eczema, a certain proportion of roughly about 30% of papillary urticaria patient may also go into atopic dermatitis, so you need to follow these patients up. And this is a kind of lichenoid AD. And as I mentioned about hand eczema, it usually starts at around 15 or 18 years of age when they start their career as a hairdresser or a dishwasher. There is atopy underneath, and along with irritant allergens, they develop this kind of pictures. We need to do patch test definitely, but obviously we need to exclude atopy. Now coming to question 3. This is the very recent entity, I can say, toilet seat dermatitis or posterior thread dermatitis. This is the kind of picture you can get. Now, it was known as a allergic or irritant contact dermatitis, but why I kept this question? Because of this article. This article actually instigated me to think about this, to frame these questions. The authors, they raised the question about the presence of atopy because patch test came out to be negative in all 6 cases. But at the same time, they admitted the fact that they might fail to detect the proper allergen. And in their advice, they, along with the topical steroid moisturizer, they also advise toilet seat cover, linen cover over the toilet seat. So they are not actually discarding the possibility of irritant contact dermatitis, but at the same time they're raising the question of presence of atopy in this entity. So with this background, I shall come to ma'am. So what do you think, ma'am? Is it a separate entity or it's actually an uncommon presentation of atopic dermatitis?
It may be the triggering factor.
Sorry?
The previous patient having history of atopic dermatitis, and this toilet seat may come in contact repeatedly.
They got family history of atopy in all 6 cases, according to them.
Maybe separate entity.
Maybe separate entity. Yeah. Setalina, do we need to ask for atopy history background kind of thing in these cases? I mean, what do you think?
I want to listen from sir. For in my experience, this toilet seat dermatitis case I have seen less often. Whatever cases I had seen, they had no history of atopy was there.
No history of atopy. Okay.
And there was particularly history once they were wearing this half skirt. They only develop. If they are wearing this
then
sports,
it didn't come back.
Sports clothes, they
got back. Got your point? Yes, sir. What is your take, sir?
See, initially, I think before this terminology came, all of us must have seen some few cases similar to this. And we never had it in mind to, at least I didn't have in mind to go into that atopic background. So, but in this study, all of them were found to be either having some other atopic condition or there was a strong family history of atopy. So once we encounter this sort of eruption, we have to keep that in mind from now onwards. Now, basically, this happens not by simple white plastic sheet. Sometimes it was reported where varnish was there on the
Varnish, yes,
wooden
varnish, yes.
cover. Sometimes some disinfectant was used and it was not properly washed. So this sort of thing was there, where this was basically a contact dermatitis on a atopic setting. That's my take.
Dr. Asutosh, as sir said, we should ask about, from now onwards, we should ask about family history or personal history of atopy. Do you agree with that comment?
Yeah, I think I agree with Ravi Vikram sir. I think it's a type of contact dermatitis for which atopics are more prone.
Atopics are more prone. Dr. Dheeraj? Sir, I shall come to you last after Sahana. Okay.
Actually, there is no confirmatory test for diagnosis of atopic dermatitis. We actually rule out, we actually inquire about atopy in family history. So if there is no patch test is negative, no family history, then it should be contact dermatitis. Otherwise, if we find any family history or any sort of atopy in...
But if you even do the patch test, what they felt that even we do the Indian standard series or scraping from the toilet seat, there are numerous allergens present in the environment. So there's a high chance we can miss anything. I mean, even if a patch test comes negative, the question mark still remains whether it is a true negative or it's a false negative. Anyway, Dr. Sahana, what is your take on this?
Sir, I feel how Sandeepan sir explained lip lickers dermatitis, like all children lick their lips, but only some of them develop it. So I feel it's a subtype of AD because all of us use
this is a very good point. Nowadays, mostly children they sit on toilet. So why not everybody is developing? Only few people are developing. That is a good point. Yes.
I can explain this because atopic dermatitis there is a barrier defect in skin. No?
Yes.
So they are prone for all types of contact dermatitis.
So in other way around, indirectly this is
maybe
evidence.
it is a risk factor, but we cannot brand this as a form of atopic dermatitis.
Oh,
that is my point.
You are not in agreement to stamp it as. Anyway, sir, your take on this.
Even school chair dermatitis are also in previously girls
were
used to skirt.
Kind of, yeah.
They will have a same dermatitis from the school chair in the thighs also.
Sir?
Basically, if you look at the, toilet seat dermatitis or posterior thigh dermatitis, whatever you may say, it is bilaterally symmetrical, right? In which type of contact dermatitis you have seen bilateral symmetry so much?
Not at all.
Right?
Yes.
Acha. In a broader sense, atopic dermatitis patients are more likely to develop contact dermatitis because of number of things: barrier repair defect, more sensitization, very sensitive skin. So somebody said that atopic dermatitis, when in touch with some contacting agent, means it is atopic dermatitis, but it is actually contact dermatitis, right? So now it is something like fighting between the contact dermatitis expert and atopic dermatitis expert in whose category the patients will fall into. But having said so, in a lighter vein, I must say that posterior thigh dermatitis or toilet seat dermatitis is a variant of atopic dermatitis only, nothing else, right?
Yeah.
So, and as many of our esteemed panelists have said, that when the child, the best advice for this type of children, and somehow I have seen it is more common in girls rather than boys. So advise them to wear a full, sleeve pant up to, knee, or a bloomer type of thing, so that their thighs do not come in contact with the school chairs, back of the thighs, or when they are sitting in the car. Right, because antioxidant of the polish of the car sheet also has been found to be causing that sensitization. So that's why some people are using it as a contact dermatitis. So that is very important.
So we can also do some study regarding this, right, sir?
Right. Put
We
for
established
thought.
Huh?
Put for thought.
Put for thought. Okay. So coming to question number 4. This is the brain tricking one. You have to think about the possibilities. If a localized patch of AD doesn't respond to topical steroid, what could be the possible explanation? Part of it already discussed by sir during his lecture, if you notice carefully. So, ma'am, what are the possibilities?
Maybe we rethink about the diagnosis or
At first,
potency of
at very first go, you'll rethink about diagnosis or something else?
no, we just first we see the potency of the steroid
Okay.
or moisturizer
Okay.
or the how the patient is applying or taking it.
Compliance.
Compliance
Yeah.
is the thing. Then we will rethink the.
So the compliance is very important factor. Before rethinking about the diagnosis, this question should be asked. That's why I always ask my patient to come back with the itraconazole strip. How many are left and how many have been taken? Yes, Svetalina, compliance then?
I also agree, compliance.
Anything
And
else?
the frequency of application.
That is also compliance. Anything else?
Then I don't think, because diagnosis I am not going to, so I'll change the treatment.
Do you think lichenified
Register.
lesion respond
No,
less?
lichenified lesion, I give, I will be very honest, very lichenified, not in children, but older children, I give
Around
in
10, 15 years.
intralesional triamcinolone 10 milligram in
Okay.
a child, I give, because I see they respond very well.
What about infection? I mean, if there is concurrent infection,
So
is it
concurrent
going to-
infection we are not going to give. So we'll give oral steroid. I will rather, if there is a infected eczema, I will go with oral steroid and topical antibiotic better. Not giving topical steroid on infected lesion.
oral steroid and topical antibiotic. You don't
Antibiotic
use
or oral
antibiotic.
antibiotic. Oral antibiotic. You'll see the infection is widespread, I'll give. If it's localized infection, single area, I'll go
You
with
will-
topical.
You will use simple topical. And why not topical steroid antibiotic combination?
No, I don't use
No, why?
topical.
What is the logic behind it?
Because I don't give mix two drugs together. So in
I have few logics in here. Sir, your take on this?
Now, I suppose Dr. Sandipardhan is treating this patient and he has explained everything to the parents and he has selected the steroid according to his expertise and the compliance is there. Still it is not responding.
Huh.
I have three things in mind. Sensitization to the topical application,
Yes.
secondary bacterial infection or fungal infection.
Yes. So how do you treat?
I will change the steroid. And if there is evidence of bacterial infection, combination with, if a single patch, combination with antibiotic,
Steroid antibiotic
steroid
combination.
antibiotic combination,
Okay.
or I can think of adding some oral anti-allergics and oral antibiotics if necessary, if there is oozing and all. And if there is evidence of fungal infection, I will add antifungal if it is required.
So according to you, sensitization means if there is any possibility of allergic contact damage. That's what you want to make.
Right, to the molecule or to the preservative or to the vehicle.
Yes, Dr. Asutosh, you want to add something?
I agree with Vikram sir. When it is not responding, we have to think of colonization with either bacteria or fungal, malassezia.
See, there are
and
two drawbacks of using this steroid antibiotic combination. Number one, cost-wise, steroid antibiotic combination is a costlier option. This is number one. Theoretically, you are inviting resistance, right? But still, off the court, if you ask me personally, I use. But these are the two possible. Yeah. Anything else you?
And there is possibility of some allergen is there, which is keeping on the inflammation.
How easy it is? I mean, how easy or difficult it is to pick allergic contact dermatitis on a eczematous patch? One clinical clue, as sir said, it is not responding. Anything else? Any other clinical clue you want to share?
Another tachyphylaxis to the.
That's what I mean.
Yeah.
We are discussing, not responding.
Okay.
Dr. Dheeraj, you want to add anything? No. Dr. Shahana?
I have a mnemonic which I read in my internship that there are 4 Ds: disease, drug, dosage, and duration. So
Okay.
whenever something is not responding, you check all of them.
Disease,
Disease, drug, dosage, and duration.
drug, doses, and duration. Yes, sir. Your final take on this. It's because I feel I become able to ignite the fire steroid antibiotic or plain antibiotic?
See, basically, most of the things have been said. Dr. Ravi has very nicely highlighted that what are the conditions associated dermatophyte infection or bacterial infection. But here I want to use a steroid antibiotic combination. As I showed in my presentation also, it is basically reserved for areas where the Staph aureus colonization is very high, like wave spaces, anterior nares, external auditory meatus, blah blah blah, all these areas. But by and large, if there are atopic dermatitis like patches or eczematous patches over the trunk or limbs not responding to topical steroid, and I'm suspecting bacterial colonization, I would rather give a oral antibiotic, anti-staphylococcal antibiotic, either amoxicillin clavulanic acid, but not for 1 week, at least for 2 weeks, along with topical steroid. So that will be a right approach actually.
Right. What about the lichenified lesion, sir?
Lichenified lesion, see, lichenified lesion doesn't respond to anything actually. That is the difficulty. The problem is that in skin of color, now there is a special wing has started in International Eczema Council, that is the atopic dermatitis in skin of color, and the 4 persons have been engaged to do research and plan all academic activities. So one of the 4 persons is myself. We will look into more in detail in different parts of the world. 4 persons are for different. I am from Asia, one from South Africa, like that, one from America, basically Mexico. So we often discuss the 2 things which are most difficult to treat in Indian atopic dermatitis or atopic dermatitis in skin of color. One is the lichenification, and second is the hyperpigmentation. But we have seen that hyperpigmentation resolves to a great extent after use of dupilumab. That is our experience. And even with tofacitinib, oral tofacitinib also hyperpigmentation to an extent resolves.
Cyclosporin also.
Cyclosporin little bit, not for atopic dermatitis, but for more for lichen planus, citrullinum. So lichenification or lichenified lesions is very, very, very difficult to treat. Honestly speaking, it doesn't go actually. It doesn't
with
resolve.
topical, it's very difficult to treat. That is the takeaway.
If it not even with oral also. If it is resolves, you have to think that you are treating a case of lichen planus hypertrophicus, not lichenified atopic dermatitis.
Yeah. So I just want to show this picture because it's a very important topic. Yes, allergic contact dermatitis is very difficult to pick up in a setting of atopic dermatitis. 2 clinical pointers you will have. One we have already discussed, either the patch will not respond to topical steroid, or there might be some aggravation following use of topical steroid. These are 2 clinical pointers. Another clinical pointer is asymmetrical location, just like this. This area is in touch with this heavy metal contact, and definitely you can do patch test, but always you will not get positive results. So there are fallacies, these persist. How many of you finding this discussion extremely boring? Please raise your hand. How many of you finding it extremely boring? Now, how many of you finding it extremely exciting? Only. Okay, then we are discussing the right things. Okay, chalo. Now, again, ma'am, a case of severe AD is not responding to full dose of cyclosporin. What could be the possibilities?
Maybe cyclosporin resistance or
Cyclosporin?
resistance.
That means the dose we are using might not be sufficient. Okay.
Yes. Then it could be poor blood level.
Poor blood level. Okay.
Yeah.
Pharmacogenetics. Yes. Anything else?
Maybe some other triggering factor is there.
Like infection and all this, we have to treat it. Yeah. Anything else? Okay. Now coming to Svetalina. So this is a very pertinent, point raised by ma'am. Mostly we use cyclosporin up to 5 milligram per kg per day, right? So if you face this kind of cases, do you want to exceed 5 milligram?
I will share few of my experience. In my practice, if I have to give cyclosporin, I used to start with 5 milligram per kg body weight. So
You
I
start from
start
high
from
end,
5.
yes.
Okay. So I have
Now-
given 5. Now I've seen few cases coming to my OPD, and that severe AD, and they had given cyclosporin, and the patient was having eczema herpeticum. So that's, you should keep this possibility and don't treat eczema herpeticum with cyclosporin. When you are giving cyclosporin, it is going to aggravate. Then this
Then we
is
have to
one
stop
scenario.
it. We have to stop it, treat the
Yeah.
eczema first, eczema herpeticum first, then we
Then you
right,
decide.
right,
This is
right.
one scenario.
Yeah.
And second scenario, cyclosporin, we lost the child. Intractable atopic dermatitis didn't respond to full dose of cyclosporin. Then the patient was having hyper IgE syndrome. So in that case, you think of, if you are giving a treatment which is like Brahmastra in atopic dermatitis, is not responding before switching into some biologics. So you should think of your revising or whether the patient is having any immunodeficiency or like hyper IgE syndrome. This is a second scenario. In these two cases, I have seen and other infections also.
Yes,
Because these two things people
very
miss.
pertinent points raised by Svetalina. Obviously, if it is not responding, you need to suspect primary immunodeficiency. Yes, sir, your take on this.
Yeah, most of my cases have responded. Maybe complicated cases go to the Apex hospitals and all. But if the full dose of cyclosporin is not giving response, then we'll have to look for triggering factors which might be cancelling out the beneficial effect, or we'll have to suspect that there is something which is mimicking atopic dermatitis, but is not actually actually atopic.
Have you ever escalated cyclosporin beyond 5 milligram?
No, I usually start with a lower dose, 2.5.
Oh, you gradually escalate.
I gradually escalate.
Okay. Yes, Dr. Asutosh, anything else you want to add except those?
Yeah, I think all pertinent points have been discussed. Another thing, we have to think of our diagnosis, and other drugs, concomitant use of other drugs which are lowering the
drug interaction. Definitely, this is also very important point. Thanks for remembering us. Yes, Dr. Dheeraj.
Yes, almost all things are covered, and nothing to add.
You have nothing to add. Okay. Any Sana? So, sir, your final take.
Escalation of cyclosporin dose, I have given up to 7 milligram of cyclosporin.
That's why I've kept the question. This message should be clear and loud. We use the dose not that much panicky.
Actually, the dose of cyclosporin, because I work in a child hospital, Institute of Child Health. We have all subspecialties of pediatrics actually, pediatric cardiology, endocrinology, rheumatology, gastroenterology, immunology, everything. And Institute of Child Health is the first teaching children hospital of India, established in 1957. So we have got a heritage and we have got huge, subspecialties. And the advantage is that we refer our patients and we get cross referrals, and we discuss with our, colleagues. Pediatric rheumatologist and pediatric hemato-oncologist, for their children, they give cyclosporin for the same age group child at a dose of 10 to 12 milligram per kg of the body weight, which is just more than double of the dose they give, but they closely monitor. So nothing to do panic. For a short duration, you can give up to 7 milligram, 8 milligram of cyclosporin, but monitor hematologically and biochemically properly, and that is all only for initial few weeks. Then you gradually go down the dosage schedule and come down to 3 milligram or 2.5 milligram, something like that. And not that you cannot escalate the dose. There's nothing hard and fast rule.
We can escalate.
Yes, you can and you should.
And even if it is not responding, you can go for dupilumab and other options.
Before, because dupilumab is definitely exorbitantly costly as compared to cyclosporin.
But we have something in our hand, right?
Yeah, right.
And this is a revision of our diagnosis. See, actually, if we make a habit to palpate the lymph node, liver, spleen in a case of severe AD, we might not miss those immunodeficiencies. This is a habit we should develop. And thorough history taking is very important. As far as metabolic disorders are concerned, if a severe eczema not responding, then ask for any history of seizure, development and Lille and all this, you will get some pointers towards the metabolic disorders. And similarly, if there is a history of frequent infections, that might point towards inborn error of immunity. And the most important point, which sir reiterated times and again, that is liberal use of moisturizer. No matter whatever molecule you are using, if you don't use moisturizer, ultimately you will end up in frequent relapse. And that's what has been mentioned in all the literatures. Not only at moisturizer improve the quality of life, but at the same time reduces the requirement of immunosuppressive in long run. You might need, but gradually the requirement will reduce with time. So I'm just giving you an example. This child has been admitted in our Institute of Childhood with this severe infection, actually a superimposed infection with severe AD. Initially we treated him with IV antibiotics. This is at the after clearance of infection. We started him on oral cyclosporin full dose. This is after 6 weeks of therapy, and he was started simultaneously with moisturizer from the day 1. And this is the after 1 year treatment. Obviously we continued moisturizer till now, along with we added weekend topical steroid. Yes, we needed few courses of cyclosporin, but what I am reiterating with every line, that we should use moisturizer liberally so that cyclosporin requirement will reduce with time, dose and duration. And for any immunosuppressive for that matter. So you can get this kind of excellent result. Now this is a question. So as I have raised about the use of weekend topical steroid, anybody could take it up. Obviously most of us practice this proactive approach with topical steroid. Anybody practice proactive approach with topical immunomodulator? And if so, if you compare TCS and TCI, what do you think? What would fit better for control of flares? Anybody could take it up.
For acute phase, TCS is better,
TCS
and to
better.
to maintain TCIs.
Anybody want to differ? TCI better or TCS better for proactive approach? Because we need to control the inflammation to a subclinical level. Sahana?
Sir, I think when you say proactive, you mean that the disease is in control and there
Disease
is no
in
flare.
control.
So I would go for TCI always in proactive, because there is no active disease when you are doing proactive management.
But subclinical inflammation is there, na? So
TCI
what would be
should
the better
take
option?
care of that.
Subclinical inflammation is always there. So what would be the better option?
See, basically I have shown that our own meta-analysis of the data of the studies published. So long-term intermittent topical tacrolimus as a proactive treatment for atopic dermatitis is now well established all over the world. The first article came in Journal of American Academy of Dermatology, JAD, way back in 2008, I think, 8 or 11. So now it is established. So during when there is no acute flare, there is no need of giving topical steroid.
Okay.
Right? It has got its own disadvantage. So better you give, topical tacrolimus is also an immunomodulator. It also has got an anti-inflammatory effect. Then why do you want to make the skin prone to hypopigmentation, telangiectasia and thinning? There is no need.
Topical tacrolimus is fair enough to control.
Sir, I want to make a point. So, because proactive, there is no skin disease at all, so you are using, because giving treatment to prevent. So, if it is thick palm and sole, I will not use tacrolimus in
that
palm
will
and
not
sole.
penetrate, yes.
Still not penetrate, it is wastage of money for the patient also. But other areas, because space and the
But
others.
why do you give this proactive approach? Over the affected area which is not active at present, or over the,
affected area.
affected
also
area
affected.
only? Okay. Yes, sir.
Why do you need to give Cetolina over palm and sole? I mean, you mean to say previously the eczema was there? If there is any hand eczema. So basically, if there is any hand eczema, there is no, once it is completely resolved, there is no need except topical moisturizer. There is no need of any steroid or tacrolimus either. You are very right in saying that topical tacrolimus, this is a very important point I just want to tell, particularly for our residents. What is the molecular weight of steroid? 586 kilodalton. What is the molecular weight of tacrolimus? 1008 kilodalton. So that's why tacrolimus does not penetrate that well into the skin unless and until it is properly moisturized. And over very thick skin, it doesn't penetrate. That is what Dr. Setalina very rightly pointed out. And that's why she is the editor of the Indian Journal of Pediatric Dermatology. Right? So, topical steroid you should consider where the skin, permeability is good. But if the permeability is not good, then don't waste topical tacrolimus. I fully agree with her on that account.
Yes, sir.
I have my opinion and one doubt also which I would like to put forward. My opinion of proactive approach when the disease is quiescent is proper maintenance of hygiene, proper use of good moisturizers as just discussed in the presentation by Dr. Sandeep, and avoidance of allergen exposure. This is my proactive approach.
Definitely, sir.
No.
Yeah.
That is my opinion. I might be differing. I am of the opinion strongly that immunosuppressives, be it TCS or TCI, topical or oral, have to be used only when you have evidence of even initial inflammation or established inflammation. Otherwise, I don't use. I might be wrong.
So you
now,
believe in reactive approach?
right.
Otherwise?
Reactive, but I am
Whenever there
telling
is
that also, that moisturizers and avoidance of allergens and proper lifestyle.
No,
that is
fine.
my pro.
Yeah.
Now, another thing, there was a concept of atopic march.
That I will come. That will come.
No,
sir.
just a question. There it was said that if you give oral antihistamines for 5 years, that takes care of the atopic dermatitis also, and that takes care of the precipitation of asthma, which is more in atopics than others. That was what we used to read 8 to 10 years back. Now there is no talk about that. Even now the consensus is that even oral antihistamines are not required in atopic dermatitis too much. Now, I would like to have some opinion of our experts on that also.
Sir?
So, atopic march, I'm sure that all of you know that
We have a question, sir. We have a question.
Question, okay, fine. So, I won't talk about atopic march.
So now I'm giving you another scenario.
तूने फिर सर करके क्या बोला मेरे को फिर क्या पूछा?
No, I just don't want to continue you on atopic march. I'm just joking. Okay. So this is another scenario. Just see the child, only face is involved. This much of severe eczema. So my consideration is: do you want to call it as severe AD because it's compromising the quality of life in a big way, and do you want to use any oral immunomodulator here or not? Anybody could take it up, or you will just treat it as a topical, limited, mild or moderate.
For few initial 4, 5 or 10 days maximum, I'll use oral steroid with moisturizer and plus antihistamine.
For this case?
Yeah, because it's
oral steroid and moisturizer. Yes, Setalina?
And antihistamine also.
Antihistamine, okay. Setalina?
The patient life, sleep disturbances
okay, got your point. That means you consider it as a severe AD. Yeah. You want to improve the quality of life. Yes, Setalina?
I will rule out eczema herpeticum. There are few
yes.
well-defined circular erosion.
Suppose ruled out. Okay,
so I will see if my first option will be cyclosporin if patient can buy. If patient cannot buy, I'll go for oral steroid.
Along with moisturizer and all. Sir?
I will treat it as a severe case.
You will treat it as
yeah.
Anybody want to differ? No. Sir, now you can tell.
This is the ideal case for oral cyclosporin actually. If the child has a face like this and we can see the blood dots on the skin, we can appreciate the degree of pruritus, and that pruritus cannot be controlled by anything, any antihistamines for that matter. Oral steroid short course still we do recommend. We have recently published from International Eczema Council in British Journal of Dermatology in 2019, the role of oral steroid in control of atopic dermatitis, still it is valid. But the question is that it has to be given for short duration, 2 to 3 weeks, not beyond that, and not very high dosage. Now the question is, once you stop the oral steroid, within 2 to 3 weeks it will relapse. So for that, those who cannot afford cyclosporine, what I do, this is now what people are doing all over the world. Start oral steroid and methotrexate on the same day. This I have been doing for last 10 years. And gradually taper off steroid within 3 weeks maximum. Continue methotrexate. The amount of improvement which you get, 70-80% of that improvement will remain as long as you continue methotrexate, even after you stop methotrexate. And in methotrexate, we have got huge experience. Next to rheumatologists, probably dermatologists have got the largest experience with methotrexate. So we know how to treat with methotrexate because of our experience with psoriasis. So continuously we can give for 7, 8, 9 months or even 1 year or even 2 years in between some gaps or pauses during summer season, taking the advantage that during there is some natural remission of the disease and properly monitoring for biochemical and hematological parameters. Yes, sir. Dr. Ravi.
Suppose the family can afford cyclosporin, will you consider substituting methotrexate with cyclosporin together with steroid when you are starting?
Right. So what I'll do, I'll give cyclosporin straight away, no steroid from the very beginning, knowing fully that cyclosporin takes at least 7 days to exert its effect. Steroid is the only molecule which shows result within 24 hours. Nothing works like steroid. But cyclosporin can be given for long-term purpose, 7-8 months, which steroid cannot be given. So I'll prefer, if the patient can afford, I'll go for cyclosporin, but I shall explain to the parents that this is a long-drawn battle. There may be good improvement within next 6-7 months, it will completely resolve, but don't expect that resolution will last for next 5 years. Be prepared that every year the child will need few months of cyclosporin. That counseling I always do.
Question. Which one you will prefer, cyclosporin or methotrexate? But sir, means both are is a patient can afford, but which one means side effects are more in combination?
No, I am not talking about combining cyclosporin with methotrexate. No. I am talking about giving either cyclosporin or methotrexate. I talked about combining steroid and methotrexate for the initial 2-3 weeks.
But taking methotrexate once in a week or twice in a week, more patient are affordability and the chances of it is means school-going children. The patient can miss this cyclosporin doses 1 or twice in a week or daily. But methotrexate he can take weekly. That is easy to.
Usually patients don't miss cyclosporin because they know if they miss the cyclosporin, the rebound is going to occur and they face the music. That's why they don't miss it.
So the message is very clear and loud from this podium. Always don't go by the morphology and area of involvement. As far as the severity is concerned, always consider quality of life. This is actually a case of severe AD, and here you need systemic immunomodulators. Now, moisturizers, our discussion is incomplete without moisturizer. If you see this Indian consensus guideline, moisturizers are on top, whether it is mild, moderate or severe variety. Even in European guideline, use of moisturizer has been stressed upon in each and every forms of AD. And even these guidelines also reiterated the same fact. Moisturizers are very important for improving quality of life, reducing the requirement of immunomodulators and so on. As sir said, occlusives, they occlude, and humectant, they hydrate. So this is a kind of schematic diagram depicting the mechanism of action. Now this is a very pertinent question I just want to ask all of you. Sir has covered almost all questions, how much to use, how frequently use and all this. This is a very pertinent question. Probably many a time I become confused which moisturizer to use where. So I am giving you some scenario. You just tell me what you want to use. Emollient, occlusive humectant, or therapeutic, or ceramide based moisturizers. Simple xerosis. Family history of AD is there. Otherwise, this is a simple xerosis. What do you want to use? Anybody could take it up. Single answer.
Mineral oil, if patient.
Sorry?
Mineral oil apply, coconut oil
Coconut oil,
application.
emollient.
Emollient.
Svetalina? Same. Anybody want to differ?
This is in atopic child. Atopic child.
Only xerosis is there right now. Maybe develop in other features in near
If,
future.
if the family can afford, I will always go with a ceramide-based
Ceramide. Dr.
moisturizer.
Ashutosh, want to differ if you or emollient?
Urea-based moisturizer.
Dhiraj?
Emollient will suffice in this
Emollient.
case.
Sahana? What is the logic? Emollient or urea based?
Based on the affordability.
Based on affordability, sir.
I think I'll go with all of them, most of them. That it for this kind of xerosis, we don't need to unnecessarily heat hard. Okay, heat hard. Simple moisturizer, white salt paraffin, liquid paraffin is more than enough.
So, pocket-friendly moisturizer, emollient kind of thing will do, right?
Right.
So now, if this is the condition, now the xerosis is a bit more with larger flakes, and you can appreciate the erythema. Now, ceramide. You want ceramide? Yes, ma'am.
I will use ceramide-based moisturizer.
Anybody want to differ? And you have to give the logic why, because
Because it repairs skin barrier.
barrier
also.
defect is more than previous one. Yes. Anybody want to differ or
No. This very obviously shows that this is an atopic child, and this what Sahana showed, Hartog's sign is positive. The medial 1/3 of the eyebrows are sparse, so you have to hit it hard. And ceramide-based moisturizers are best to control the disease, because we know you have also mentioned so many times that good moisturizer is steroid sparing. That we have to remember. That by use of moisturizer, we are basically keeping the steroid away, right?
So after a few months, when the disease will be under control, do you want to shift to simple emollient?
Yes.
Just for cost
Yes.
cutting? Yeah.
That is the principle of treating atopic dermatitis. Change of or tailor-made choose the moisturizer in a tailor-made way, as and when necessary, as much and as little it is necessary. That is the basic dictum.
This picture has already been shown by sir. I want a very specific question. See the abdomen. Do you want to use ceramide or occlusive emollient combination? Occlusive humectant combination.
Occlusive humectant combination because lichenified.
Lichenified?
Face
Okay.
I will use serum.
Anybody want to differ? Ceramide, occlusive humectant. So everybody agrees with occlusive humectant. What about the face? Do you want to use any moisturizer over the face? Because this is a oozy lesion. Do you want to use moisturizer? Ceramide lotion. Anyone else? I mean, doesn't it aggravate the staph colonization?
If it is infection is there, I will not use.
So it's already evident,
This
na? There is a oozy lesion.
Oozing doesn't mean only infection. It is eczema can also have oozing. You have to mention there is infection.
No, you have to appreciate. I don't.
You have to mention there is infection.
Sir.
Yes, antibiotic has to be given. Oral anti-staphylococcal antibiotic.
Oral antibiotic
yes.
along with
Well, along with you give moisturizing cream over the face. It is better to give cream. Cream means something which is emollient type, not very greasy.
Very greasy. Okay.
Because greasy things are not acceptable over the face nowadays, even by the small children also.
Got it. Now this is the question. Already this point has been raised. Ceramide or so. I have a reservation. This actually nowadays this ceramide-based moisturizers are flooding the market. So, are these superior than conventional urea-based, petrolatum-based moisturizer? Do you believe so in your day-to-day practice, or there is any evidence? Anybody could take it up.
There are studies which show that though transepidermal water loss is controlled almost the same level as simple moisturizer, but SCORAD score improves earlier with ceramide-based moisturizers.
So, is there any head-to-head trial, sir? I'm not aware of that.
And there have been. I have seen some reports.
Oh, there are trials.
Yeah.
The ceramide-based moisturizer better in
SCORAD,
controlling.
as far as SCORAD goes,
SCORAD.
not the transepidermal water loss.
Okay. Anybody want to make any comment? So, sir.
ceramide-based moisturizers have been trialed by, many authorities of atopic dermatitis in the world, and head-to-head with just ordinary moisturizer, and it has been shown that they are much more efficacious for very severe barrier repair defect in the atopic dermatitis.
Dr. Asutosh.
I think both reduces the transepidermal water loss, one by repairing the barrier repair function and one by occlusive action. So what makes the difference?
That's what I just want to ask from you. I want to know from you, what makes the difference? So what do you prefer? Barrier repair or emollient? If both are same, then what is the use of, spending more?
In my practice, I feel occlusive are cheaper than ceramide based.
And
So affordability is
efficacy
point.
wise, as sir said and other panel said, ceramide based moisturizers are better. So
Another
what do you feel?
is for atopics are mostly have dry skin. So for them, the 06 part goes up to the month of April, May. So we can go with occlusive.
Yes,
Inflammatory effect is there. No?
Anti-inflammatory
Yeah.
effect is there. So to connote that, now there is 10 years back this concept is different, both are same, or we do not spend more unnecessarily, but now there is a shift, gradually we are shifting towards ceramide moisturizer to connote that ceramide based moisturizer nowadays are welcome.
Number of application time increases in emollient.
Sorry?
Number of application time. Emollient should be used more frequently than ceramide.
Ceramide less,
Yeah.
due to its efficacy. That's what you want to
Yeah.
mean. Okay, that's the point. Question 10. This is a question, sir, raised about the atopic mud. So I'll start from sir only. Is it possible to prevent the development of AD with moisturizer, sir?
The prediction part I don't get, but prevention part is clear to me. Moisturizers are the basis of treatment of atopic dermatitis, be it active disease or be it disease in quiescence under remission. Moisturizers are the basis for treatment as well as prevention. Now, because due to the filaggrin gene defect, this filaggrin abnormality, there is decrease in ceramide. So the pH is changed. That's why ceramide-based moisturizers theoretically are better, and only time will tell in our practice whether they are actually better or not. But going by theory, I will be preferring ceramide-based. Now, I don't get the part about the prediction of development of AD. It's not clear to me what the question asks.
Anyway, you take it as prevention.
The moisturizer does prevent the flare-ups. It is the basis of it.
My question to Sandeepan sir, if moisturizer can prevent development of future AD, how can you pick up those cases who are the ideal candidate for application of moisturizers? There is no clear-cut evidence of AD up till now, but how can you cluster those cases?
Basically, these cases are picked up on the basis of high risk, they fall into the category of high risk group. So high risk group means what? The mother and father, either both of them have any sort of atopy, either bronchial asthma or allergic rhinitis or atopic dermatitis. The mother has got another, child who has got atopic dermatitis or very severe bronchial asthma. So there is a clustering of atopic features in the family. So this child is likely to develop some sort of atopic feature. Probably looking at the skin, you can make out the dry skin and the number of other siblings having atopic dermatitis. To identify these cases as a potential cases for going into atopic dermatitis, the two large studies which were carried out, not many years ago, just 5-6 years ago, one by none other than John Hannifin, Andreas Uhlenberg from Germany, and many others, Simpson from America, Amy Peller from United States, and the other study group is also equally heavyweight group from Japan, Tanoka, Then Ritamo is the person who used topical tacrolimus first time in the history of dermatology for atopic dermatitis. So both these studies actually showed that it can delay the onset of atopic dermatitis and it can prevent in a significant percentage of children who are likely to develop atopic dermatitis in high risk cases. So since then we believe strongly that within few weeks after birth, if the baby is moisturized in a high risk setup, then then the chances of development of atopic dermatitis is less. And this is called primary prevention of atopic dermatitis.
Only 2 questions left. Should we close or we'll continue?
Continue. Good discussion.
Please raise your hand. Or
They have
Now-
to take the prizes also. No?
Now, as of now, the world is divided into two. I mean, whether to use crisaborole or not. A school of thoughts, they said no, it's not that much effective. One school saying no, it's effective. And before that, I just want to ask why there is a need of some of this newer molecule. I mean, these existing molecules. I mean, what we have in our hands so far, we have discussed topical steroid, topical tacrolimus. Are not they working? Why there is need of any newer molecule? Just to give us some variation to our prescriptions or
No, to reduce the dose of steroids, to reduce the dose of the load of steroid on the patient, and for maintenance.
the maintenance we have pimecrolimus, tacrolimus working very well. So why do you need newer molecules, sir?
Yeah, the more tool we have in our armamentarium, the better we are equipped to deal with various cases, because each and every case is not the same.
Yes, that is the point. In each and every cases, topical tacrolimus will not work. This is a very much variability, high variability present. This is present in AD patients. Yes, anybody want to make any comment?
I feel there are new mechanism of action and pathophysiology which is being discovered in AD every day, and there is a drug which targets that specific pathophysiology. So crisaborole is like that. It's a different mechanism of
Maybe
action
10 years back we are not that much aware of the PDF4 inhibitor, PDF4 activity, right? So since we know this, we should have something to block that pathway. Yes, sir.
Basically, no. I just ditto what Sahana said. That earlier we used to know couple of concepts about the pathogenesis of atopic dermatitis and the mechanism of the drugs which are useful for atopic dermatitis, like calcium channel blocker, orally cyclosporin, topically tacrolimus. Now newer concepts have come up. Is a PD phosphodiesterase 4 inhibitors, orally apremilast, which works in some small segment of patients of atopic dermatitis, and topically crisaborole. Even further newer development is the JAK-STAT inhibitors. So, and before that, IL-4, IL-13, IL-31 inhibitors, biologics. So it is an evolving concept. Research on atopic dermatitis has not ended, neither it will ever end. For your all of your information, let me tell you, do you have any idea that all over the world, in all dermatologic journals and non-dermatologic journals, how many articles are published on an average on atopic dermatitis?
Any guess? You will get a chocolate along with the quiz prize.
Per day, 2.5 articles, 2.5 new articles are published. So it is not possible for any human being to read everything, each and everything over atopic dermatitis. That is something which is very clear. That is what I wanted to convey to you.
Now about crisaborole, do you like it, sir? Does it work?
See, basically crisaborole, I initially treated my patients with original crisaborole, just like tacrolimus. That is a eucrisa. In Indian rupees, my NRI patients, they got for their children. In Indian rupees, a 60-gram tube costed, I asked them how much. They said 58,000 Indian rupees, right? So somehow it has become now available in India, and cost is though high, but not that much. It is 1800 to 2000 maximum. So in some companies even has got cheaper crisaborole. So, but peculiarly, let me tell you, many a times we have got the concept that something which is costly means very good. It is not true. And this is very, I always believe that. And I always fight with my wife. She will always go for the costly thing, costly clothes, and this is the best. I said, no, this does not suit me. Very cheap clothes that suits me. I told you, I go for very costly glasses, but very cheap clothes. so, 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 so basically, costly molecule, crisaborole, had lot of irritation potential, eucrisa. But the crisaborole which is available in India, I am treating patients, we have done a trial, but the irritation potential not that much, even much less than tacrolimus also, in fact. Right? But yes, it is for small children over the face, over the flexor, it produces much better effect, faster effect than tacrolimus or pimacrolimus, and persistent effect. And the burning potential is not that much as we earlier used to feel.
So are you gradually replacing tacrolimus with crisaborole for mild cases?
Those who can afford. Those who can afford.
It's
It is
still
not
a costlier option.
Yes, it is always better to say that yes, this I didn't know, now I know about it, rather than saying that yes, I know everything. It is not possible in science. So every day you should, there is a saying that if you have not changed some of your concept of yesterday, check your pulse, you might be dead.
So you have to have something up your sleeve. Don't always go by the conventional. You need some extra molecules. But another question regarding crisaborole is there any head-to-head trial, sir? I mean, this is your personal experience, I can understand. But is there any head-to-head trial between crisaborole? Because most of the articles I have found, they have crisaborole has been compared with placebo. Is there a head-to-head trial with tacrolimus or pimacrolimus, or any research is going on that matter?
Internationally, unfortunately, not so far.
Okay.
But I am a part of a head-to-head trial between crisaborole and tacrolimus in India, along with Abhishek De, and we will get the data by, maybe by July, August, or maybe by the end of 2025.
This is what I want to know from you.
It is an ongoing trial.
Now,
Head-to-head trial between crisaborole and tacrolimus.
Now this is the last question, almost same question. Personal experience with topical tofacitinib. I will not ask why topical tofacitinib. My question is that why ruxolitinib got approval, tofacitinib not? Because I mean both are the JAK inhibitors. I mean if this is Sar's article, and both work in different, different JAK pathway. Probably the cytokine profile is different, or what is the reason? Tofacitinib we are using like anything, but ruxolitinib got approval. Is there any valid point? I mean, efficacy-wise, side effect-wise, tolerability-wise?
The reason being, to my mind, Abhijit, to my mind, the reason being, tofacitinib is pan-JAK inhibitor.
Yes.
Right? Ruxolitinib is perhaps not pan-JAK inhibitor.
No.
Look at it.
No.
So it is a specific JAK inhibitor like abrocitinib. And again, further advantage is it is topical. Unlike abrocitinib, which has got its own disadvantage of being systemic, some adverse effects.
And as you have mentioned in the article, only ruxolitinib has been titrated against topical steroid.
Yes.
That is an important point, probably, sir.
Right. Yes. Yeah. You are very right, Abhijit.
Efficacy-wise, it is found to be equal or even more than that of a mid-potent topical steroid.
Correct.
But we don't have any.
And ruxolitinib is going to come in Indian market in next 2 years. Take it from me. In next 2 years, it will come at much lesser cost. Right now, the cost of ruxolitinib, if you want to buy it from USA, it will cost you only 1 lakh rupees.
So
for 60-gram tube.
Yes. So I'm just framing the question in a different way. Any particular subset of patient, those who respond to topical tofacitinib better? Do you have any experience like that? I mean, have you ever used anybody?
First of all, I find topical tofacitinib better than crisaborole.
Okay.
And even tacrolimus in general limbs and body. Tacrolimus works, in my experience, better in the intergynous and facial areas for atopic dermatitis also,
Okay,
compared to limbs and body and palms and soles. But tofacitinib works better, at least compared to crisaborole, especially in psoriasiform changes where there is psoriasiform changes or mild lichenification for tofacitinib. In my limited experience, I have found to be very effective compared to the other two. But again, the approval part is there. You can't use it below 2 years. The oral is also not allowed below 2 years, I suppose. And topical also, I keep it a point that I use it above.
Dr. Asutosh, you want to make any comment?
Yeah.
I am winding up. So, just to conclude that AD is a extremely enigmatic, dynamic disease evolving every day, and that's why probably Dr. Sahana has mentioned something called, some entity called in between AD and psoriasis and evolved, and that is because, as Sir mentioned, because every day we are going to know something new about AD pathogenesis. Now these Th17 and Th22 cells, these are also have been implicated in the pathogenesis. So keep learning, keep studying, and keep attending this kind of interactive sessions. So thanks for your active participation. You are a wonderful audience. We are winding up. Otherwise, you will give me gully because everybody of you are very much hungry. Thank you very much.
Wonderful moderation, Abhijit. One more clappings for Abhijit.
So, you just open the answer sheet and tell the answers. I'm just giving. So, this is the time for the answers. So we have 5 winners, right? So, question 1 was, which of the following is not true about atopic march? Anybody could volunteer, please, PGs. Anybody could volunteer. Oh, already given, na? So no need. So this is the answer. Availability of biomarker has made it easy to predict the future development of atopic march. This is a wrong information because up till now, as of now, we don't have any specific biomarker to predict the development of AD. Question 2, which is of the following is false about prevalence of AD? Severe cases become much less frequent in recent year. Obviously, by now you are quite aware of the fact that severe AD, we are getting more and more severe AD, so it's a false information. Which one is correct about dupilumab? It is not a TSLP inhibitor, it is IL-4 and 13 inhibitor. And this is a wrong information, available as IV injections. Only initially it was approved for 12 years or more, then gradually the lower limit has shifted to 6 months. That actually express the researchers' faith on these molecules, its safety profile. Question 4, all of the following are correct about leaky gut hypothesis. So last one is the wrong answer. Inadequate microbial exposure keeps neonatal immune system Th1 dominated. Initially, actually, when neonate takes birth, it is actually Th2 dominated and sterile. This is the wrong answer. Inadequate microbial exposure keeps the neonatal immune system at Th1 dominated. With sufficient microbial colonization, gradually it shifts to Th1. Question 5, all of the following are correct about clinical manifestations of AD. As Sir reiterated the fact again and again, discoid eczema is not a separate entity anymore. It's actually a presentation of AD. Any question left also? So these are the winners, Dr. Srirupa and Dr. Suraj Kumar Keshri. Big round of applause. Oh, few more, sorry. Dr. Sangeeta Singh, Dr. Irene Matthews, and Dr. Devopriya Pal. So big round of applause. I would like to request Professor Dhar to please come over the dais and felicitate our winners. So, very exciting prize is waiting for you. Oh, this is a very exciting information. I shall come Dr. Sangeeta first on the dais. He got all of the questions correct. So, big round of applause for her. And Dr. Sangeeta, you are going to get a very exciting prize. It will be a treasure. Yeah. It will be a treasure or asset for your life. Please tell me, which college are you from? And
IGIMS Patna.
IGMS Patna, okay. So it's Sir's book. Which year?
First year.
This will remain as a treasure or asset for rest of your life.
First year IJMS and she has got all the questions.
All the questions correct. Really commendable.
Heartiest congratulations. Wish you all the very best. Keep it up. Take up pediatric dermatology in future. Huh?
Yes.
Next, Dr. Irene Matthews. Please come over the dais. Irene Matthews, sorry. Please introduce yourself.
Hi, I am Irene. I am faculty in AIMS Patna, assistant professor. But the quiz was too exciting to resist.
You are always welcome, Dr. Matthews.
Hello, Irene.
Next, Dr. Devopriya Pal. P-R-I-Y-A. Devopriya, okay.
Sir, I'm senior resident. Senior resident in AIMS Patna. Thank you, sir.
Now, Dr. Sri Rupa.
Hello everyone, I am Dr. Sri Rupa and I have a private practice at Sagna Mode, Patna.
Being in private practice, you have been able to keep up with academics. That is really creditable. Please, one more clappings for her. It is not easy to balance these two together. So everybody will read book. All of you who are getting the prizes, please read the quotable quotes below. बहुत तकलीफ करके उसको ढूंढ के निकाला है. And apart from Sahana, another person I found, P.K. Roy Sab, my dada. He is also very fond of quotable quotes. He told me just now, Sandeepan, wo tera quotable quotes मैं ढूंढ के पढ़ता था. And Sahana, you wrote that in Indian Dermatology group.
Next, Dr. Suraj Kumar Kesri.
Hello, Dr. Suraj. Could you just introduce yourself?
Hello everyone, I am Dr. Suraj Kesri, third year postgraduate from PMCH Patna.
Heartiest congratulations. Heartiest congratulations, Suraj. Well done. Thank you very much.
I want to thank Dr. Sangeeta once again because it took me 10 years to understand a little bit of AD, whatever I understand, but she answered it in the first year. It's really commendable. And please, big round of applause for me also.
I have prepared the question.
So, good afternoon, all delegates. Now I'd like to call Dr. Punkesh, Secretary, IDVL Bihar branch. Punkesh sir.
Thank you. Good afternoon, everyone. On the behalf of Bihar IDVL, मैं धन्यवाद सबसे पहले करना चाहूँगा एक्जिमा सोसाइटी के डॉक्टर संदीपन धर सर का कि सर ने अपना बहुमूल्य समय निकाल करके इस एकेडमिक सेशन को अच्छे तरीके से संचालित किया। मैं डॉक्टर अभिजीत साहा सर और डॉक्टर सहाना पी मैम का भी धन्यवाद करना चाहूँगा कि उन्होंने अपने व्यस्त समय निकाल करके बिहार के लोगों का ज्ञान बढ़ाया। मैं अपना धन्यवाद ज्ञापन करना चाहूँगा अपने पैटर्न डॉक्टर पी.के. रॉय सर का, अपने प्रेसिडेंट डॉक्टर ओम प्रकाश सर का और एक्स सेक्रेटरी डॉक्टर अभिषेक झा सर एंड एक्स सेक्रेटरी डॉक्टर विकास शंकर सर का कि उनके सब प्रयास से ये प्रोग्राम को हम लोग सफल बना सकें। और आखिर में मैं अपने पैनलिस्ट डॉक्टर रवि विक्रम सर, डॉक्टर सुतिलना प्रधान, डॉक्टर यूके पल्लवी एंड डॉक्टर अस्तुलन सर एंड डॉक्टर धीरज कुमार का भी धन्यवाद करना चाहूँगा। आखिर में मैं अपने पार्टिसिपेंट्स, डेलीगेट्स और पीजी सब का भी मैं धन्यवाद करना चाहूँगा कि उन लोग अपना बहुमूल्य समय निकाल करके इस तरह के साइंटिफिक कार्यक्रम में हमेशा भाग लेते हैं। और आखिर में मैं धन्यवाद करना चाहूँगा अजंता फार्मा का कि उनके सहयोग के बिना ये प्रोग्राम सफल नहीं हो सकता। धन्यवाद, धन्यवाद सबको।
Thank you so much, doctors, and sincere gratitude to IDVL Bihar branch as well as SES. Now we'll move on to the felicitations and requesting Dr. P.K. Roy sir to please come on stage and felicitate Dr. Sandeepan Dhar sir. So it's a beautiful memento along with the speciality of Bihar, the Khaja. Thank you so much, Sandeepan Dhar sir. Thank you so much, Dr. P.K. Roy sir. Now to felicitate Dr. Avijit Saha, would request Dr. Vikas Shankar sir to please come on stage. Thank you so much, doctors. And now to felicitate Dr. Sahana Raju ma'am, requesting Dr. Abhishek Jha sir to please come on stage. Thank you so much, doctors. Requesting Dr. P.K. Roy sir to come on stage again. And Dr. Sandeepan Dhar sir to please felicitate Dr. P.K. Roy sir. फोटो अलग दिखेगी सर. Thank you, Dr. P.K. Roy sir. Dr. Sandeepan sir, we would request you to be on stage to felicitate Dr. Om Prakash sir. Please come on stage, sir. Next, I would like to call upon Dr. Ravi Vikram Singh, sir. Next, would like to call upon Dr. Vikas Shankar, sir. Sorry, sir. Absolutely, sir. Right. Now requesting Dr. Abhishek Jha, sir, to please come ahead. Requesting Dr. Punkesh sir to please come ahead, sir. Thank you, sir. Requesting Dr. Ashutosh Ranjan sir to please come ahead. Thank you, sir. Requesting Dr. Shwetalina Pradhan ma'am to please come ahead. Thank you, ma'am. Requesting Dr. Pallavi ma'am to please come ahead. Madhu sir. Thank you, ma'am. Requesting Dr. Dheeraj Kumar sir to please come ahead. Thank you, sir. Requesting Dr. Anjishnu Prakash sir to please come ahead. Thank you so much, doctors. And Requesting Dr. Richa Thakur ma'am to please come ahead. Thank you, doctors. Requesting all faculty to come on stage for a group photograph. Thank you so much.
But as we have only 5 prizes, Ajanta will arrange a book for you. Okay? Meanwhile, you can have a picture with sir.
Great. I would request panel Bihar branch delegates, please give a word of encouragement to my team, and they would like to have one photograph with you, with your permission. Sir. Team, come please.
Requesting all delegates to please join for lunch. The lunch is open. Thank you.